Good morning, everyone. Welcome to C3 2020 virtual seminar today. This is a very important event, and I'm proud to say that our relationship with the European Bifurcation Club goes back many, many years. And we continue to have great sessions with the EBC every year, and Dr. Yves Louvard, who is here, Dr. Imad, Sheiban, and Goran Stankovic has been really the pillars of this fundamental relationship that has gone on for last 5 years. So I want to welcome everyone from EBC to take part in two of the EBC and C3 joint sessions, as we have not been able to do the live meeting in Florida this year. At the same time, I want to make sure that I extend invitation to all of you to be part of the live meeting next year in June in Orlando. Again, it's going to be a fantastic event again next year. And I also want to wish everyone a very safe time in whichever country you are in, and success and safety in your family and in your job. So with that said, we have a very long and strong agenda today with some incredible speakers and a pretty much a full house. We're already crossed over 400 people. So we're gonna get started here. And first we're gonna talk about fundamentals. I wanna welcome all the moderators, Dr. Yves Louvard, Dr. Sheiban, Dr. Legutko, Dr. Murasato, and Javier Escaned to moderate the first session. And now I'd like to introduce our first speaker, Dr. Imad Sheiban, who has been a course co-director for a C3 meeting for almost a decade now, and has been a very active participants on all fronts of C3 meeting here in scientifically as well as socially in Europe. And he's going to do the first lecture on how to identify clinically relevant side branch, defining the complexity of bifurcation anatomy.
Thank you, Raj, for this kind of introduction. I'll try to share my screen. You see my...
Yes, we can.
Okay.
Great.
So
beautiful.
Thank you. So first of all, I think we should focus on what is important in any vessel disease. Severity, of course, is the main determinant for any other reaction to the disease, and that is determined by angio or intravascular imaging and functional severity, physiology evaluation. Then we should consider for the vessel whether it is bifurcation or not, clinical relevance. That depends on the size and distribution of the vessel and how much covering myocardial mass. And the prognostic relevance, of course, is related to the clinical relevance. So if clinical relevant vessel treatment can be translated in relief of symptoms and ischemia, and this will improve the prognosis since it can prevent myocardial infarction and arrhythmias. Now, what about side branch in bifurcation lesion? We do not have confirmed criteria to evaluate whether it's clinically relevant. What we know is that if we have a side branch covering more than 10% of myocardial mass, then this can be clinically relevant. And this is coming from an old study from 2003. And in terms of ischemia risk, revascularization is better than medical treatment when moderate to severe ischemia exists, and when the vessel or side branch is covering more than or supplying more than 10% of myocardial mass. And this is coming from a very important study showing that revascularization of clinically insignificant side branches is not translated into clinical benefit if it is not relevant, and might be even harmful. So this is an important issue, determine whether we are dealing with important side branch relevant clinically or not. And this is also mentioned in guidelines. As you see, large area of ischemia, more than 10%, will affect prognosis. So we will be based on this to evaluate, to have some criteria to judge whether side branch is relevant or not. These are two important studies based on myocardial segmentation technique with the CT scan. And the conclusion from these studies that compared with main vessel, side branch supplied a smaller myocardial mass and showed less physiological severity despite similar stenosis severity. Side branch supplying a myocardial mass more than 10%, which may benefit revascularization, could be identified by vessel length of more than 73 millimeters. That means this is another criteria, which is the side branch length, more than, beside its size, which can give us an idea about how much myocardial is recovered. And identification, again, this is another important study, which is again to identify important or clinically relevant side branch. Side branch length should be more than 73 millimeters. In left main bifurcation, of course, we are not treating with a side branch. We are treating really with a main vessel. Then it is almost always clinically relevant. Reference vessel diameter should be more than 2.7 millimeters, and left ventricular mass more than 104 grams, and fractional flow reserve will be less than 8. That means we have some important or severe stenosis. Then if we look about major bifurcation of coronary tree, we can see that, of course, left main, LID, and circumflex is the main bifurcation and always determining more than 10% of myocardial ischemia. But if we look on non-left main bifurcation, then first diagonal and first marginal, obtuse marginal, can often cover more than 10% of myocardial mass, and then can be considered clinically relevant. But in other sites, like in distal right coronary artery, that means PL or PDA, are not always significant. That means not so frequently significant. We have this also in SNUH score coming from Korea, from KU. And this, again, you see that the score is based on the size of number of side branch. That's another important issue, to have some easy criteria on angio to judge whether it could be clinically relevant or not. That means the less of number of side branch, the more clinically relevant is the side branch. Objective and the highest, that means the distribution of the vessel. Just as schematic from KU, give us what is expressed in the SNUH score, and you see that here, if you have a big side branch, single side branch will cover more than 10, will cover a huge area of myocardium. While if you have the small one with more than one, then the side branch will cover less myocardium or will be less clinically relevant. Now, coming to a very practical thing on angio, what we are seeing, because I think if we are doing angio, we do not have time to stop to send patient for CT and then to determine whether it is a clinically relevant or not. We should be based on very easy criteria. even if it's not so much precise. But I think coming from the studies I have shown before, I think we can have some criteria. Like in this case, you can see this first diagonal, huge diagonal, size is more than 2.5, then length is much more than 8 millimeters. Then this, of course, will be covering a big area, that means more than 10%. And this first diagonal also, no other diagonals here, you can see no other diagonals in coming from LAD. And this, of course, will be clinically relevant. While in this case, we have more than one diagonal, smaller diagonal here. And you see that the diameter is less than 2.5, length is less than 7 centimeters, and this will not be considered clinically relevant. Just to show you what can produce an occlusion of side branch like this, this is bifurcation with first diagonal, huge first diagonal, very long first diagonal. And this is after stenting, only left med for preventive stenting without protecting side branch in this case. And what happened that we lost totally side branch, and this was the ACG. And you can see the severe ischemia shown also by ACG, as well as patient was experiencing chest pain. Then after we recovered the side branch, and immediately you see ACG was recovering, and patient again also angina disappeared as well. So I think these criteria, size of side branch, length of side branch, and number of side branch can be, of course, something useful to judge whether it's clinically relevant side branch on angio or not. Of course, not all bifurcation lesions are born equal. We cannot have fixed criteria and very solid criteria to judge in every patient. But what is important, I think, if it is clinically relevant, I think that the treatment should be optimal. And what is still lacking is that despite the excellent quality of Medina classification, it is not adequate or appropriate to choose whether we have to use 1 or 2 stents. And that's because we do not have all the characteristics we have mentioned before. And of course, just to show you that by Medina, this is both are 111, but I think strategy will be different from this case than the other one. Again, 111 Medina, and again, the strategy here, of course, cannot be fixed by provisional stenting. I think in this case can be absolutely provisional stenting can be the first choice, the default intervention here. But even though Medina 111 will be describing both, but they are different, and it is not adequate for choosing the type of treatment. Well, beside these characteristics, I think complexity of bifurcation also is expressed by the length of lesion on side branch, whether you have more than one bifurcation on side branch, and you can see here, this is another bifurcation on side branch, that means multiple bifurcation. And again, the axis is very important. As you see here, it's very important that to know that in these cases, when the axis is so difficult, I think first of all, side branch should be every time protected. Length of lesion on the side branch as well, and of course calcification, thrombus presence as well. So this is important because, of course, 1 stent or 2 stent strategy is important and can affect the outcome, clinical outcome. Not in all what we have seen till now, because many meta-analyses are including patients that having complex and simple bifurcation together, and this will not show exactly what is the importance of the classification or to choose the appropriate approach in each patient. Just to show you how it's important, if you are starting with provisional stenting and you are shifting to 2 stents, then the MACE on follow-up will be higher, significantly higher than if you are choosing your right strategy. That means 2 stents technique in the same patient and going as default strategy by 2 stents. Again, I think definition 1 study is well known to everybody and showing that simple bifurcation, if treated with provisional stenting, will do much better than 2 stents. But on the other side, if complex bifurcation, if treated with 2 stents, will do significantly better than using 1 stent. And this was also confirmed in definition 2 trial, which was just published this month on European Journal of Cardiology, showing again that in complex bifurcation, complex stenting, that means 2 stents, are doing much better than 1 stent. So what depends on size of side branch, length and distribution of side branch. And this is the first step we have to do. That means to fix the clinical relevance of side branch, and then to decide what is better to do, whether it's provisional stenting or not, or simple stenting. That means based on severity and length of lesion, extension of disease, the angle, calcification, and so on. Of course, about 2 stent strategy, I think we do not have a default strategy. All strategies are good. However, it should be done every time optimally. So to conclude, I think today, bifurcation lesion, the first step is to determine whether, if it is not distal lift main, whether it is side branch is clinically relevant or not. That means based on size of side branch more than 2.5 and length of side branch more than 10 millimeters, 10 centimeters. And then if not, just keep it open. If yes, if it is simple, go for simple stenting, elective simple stenting. If it is complex, go for complex stenting. Thank you very much for your attention.
Thank you very much, Imad, for a wonderful overview of that very important topic about what to do with a clinically relevant side branch. Now, to further define a coronary bifurcation using physiological testing, which is the importance of which is growing exponentially in the Western Hemisphere, especially in the United States, with a very high penetration of physiological testing. It's a very important topic. We have Dr. Javier Escaned, who is head of cardiology at San Carlos Hospital in Spain, and has been author of over 200 peer-reviewed articles and has written and spoken extensively worldwide about this topic. He will now present FFR and coronary bifurcation anatomy to assess stenosis severity of bifurcation lesions.
Thank you very much, Raj, and of course it's a pleasure to be with all the colleagues attending this webinar that has been organized by the C3 Academy and the European Bifurcation Club. These are my disclosures. Now, to me, the role of physiology in coronary bifurcation stenosis is, of course, first to set the indication of PCI, like in any other subset of lesions in the coronary arteries, but also have some additional value, like planning PCI in bifurcation stenosis, assessing side branch osteostenosis after main branch stenting, and monitoring the effect of actions addressing the maneuvers that we do to protect or to improve the result in the side branch. And I believe that these are specific features of physiology in the bifurcation lesions. So if we start by talking about the use of physiology in planning PCI in bifurcation stenosis, and again, beyond what will be the idea of setting the indication in the main branch, we have to remember that the predictive value of making physiology in the side branch is not the same like in any other vessel, because here, what is probably going to dictate that the side branch occludes during the intervention is carinal shift, and not the presence of the absence of an stenosis at that particular level. So the take-home message is that you get valuable information if you have beforehand, before starting the intervention, that you have a normal IFR, FFR measurements in your side branch at the level of the osteon. You know that you have a problem that we'll have to face later, but you will not be able to predict that you will not have side branch closure by having normal or non-ischemic FFR or IFR indexes. So we'll see that also has a very important role in the context of side branches that have other additional stenosis. I'm just going to show you an example from clinical practice because this illustrates the situation. Here you have a side branch that in addition to what you have in the osteon, has an stenosis of uncertain severity in the mid segment, as you can see. So the first thing we do is, of course, as I say, set the indication in the main vessel, in the LAD. We, of course, use nowadays IFR a lot because it, in this particular cases, is very fast, provides a lot of information. You can maneuver everything from the operator's table. And you can see that we also perform here co-registration. Of course, we know that there is a flow limiting stenosis in the vessel, and we know that is present mainly at the level of the bifurcation. So we are able to predict that if we treat that particular segment in the proximal region, as you can see, we will improve our IFR to 0.95. So far, so good. Now, the problem is what happens with this diagonal branch. Now, we interrogated the diagonal branch with a pressure guide wire, and then we can see that actually we have to start with ischemic values. Now, in the FFR era, we had a problem, because you have a crosstalk between the stenosis that you are trying to assess in the diagonal branch and the proximal stenosis located in the bifurcation. But now in the non-hyperemic era, in the IFR era, this can be solved because what you can do is take advantage of the fact that you can predict interventions. There is less crosstalk between these stenosis. So what we do is we simply isolate the effect of the stenosis from the diagonal branch. And we can see that what the system is telling us is that once that we have fixed the stenosis in the LAD at the level of the bifurcation, we should not have a significant stenosis in the diagonal. So we have contributed with this to really plan much better our procedure up to this point. And we know that we can proceed with a provisional stenting technique if we wish. So that's what we do. We go with a provisional stenting technique. I skip some of the steps that we are doing over there. As you see, we are optimizing with IVUS. And now what we do is first, we check the result in the LAD. Very good. We can see that, you know, the IFR is good. Remember that it was on this disease. We cross with the guide wire to the diagonal branch. And then we perform an assessment, and we can actually realize that the prediction that we did beforehand was good. And as you can see, the value of IFR here was basically the one that we were predicting in the diagonal stenosis before the case, and there is no pinching of the vessel. So I think that this case illustrates, in a way, the contemporary use of physiology with the tools that we have, non-hyperemic indexes, co-registration with angiography, prediction of the results that you are going to get in situations like this where you have a complex multi-vessel disease. And you can notice that the patient had an additional treatment of the circumflex that I skipped for the sake of time, of course. Are there any other tools apart from pressure guide wires that tell us or help us in planning PCI in bifurcations? Well, we have two imaging techniques. One is CT FFR, and the other one is QFR, or quantitative flow ratio. Those are functional angiography techniques. Those are techniques that merge geometrical information of the arteries with predictions based on computational fluid dynamics or other fluid dynamic equations. And what you can see here is that basically there are, I believe, strong differences between these two techniques. On one hand, CT-FFR provides a complete 3D reconstruction and can provide any orthogonal view. So you have no problems whatsoever in visualizing properly the vessel. And it has, therefore, you don't have problem of vessel overlap, and you have very robust hemodynamic calculation based on true computational fluid dynamics. QFR, which is something that we can apply in the cath lab from two orthogonal views, is limited by the orthogonal views that are provided by the C-arm. Sometimes they cannot be truly orthogonal. You may have branch overlap as a limiting factor, and the hemodynamic calculations does not take into account branching vessels. So for the time being, and it has been highlighted before by Imad Sheiban, the CTFFR may provide additional advantages because, as he also mentioned, it can also provide an estimate of the subtended myocardial mass to the side branch, which of course will help us in deciding when we are performing PCI if we have to really encourage a good physiological result in a branch that provides blood flow to more than 10% of the left ventricle. Now, how do you use physiology during PCI? That was planning what we have discussed so far. How do you use physiology during PCI in bifurcation stenosis? Well, I find that the main role is assessing the functional results in the main and side branch. And I think that the previous case was a sort of trailer to this type of use. I believe, as I demonstrated to you before, that is facilitated a lot by the use of non-hyperemic indexes like IFR. And also, I will try to show you now how you can use this physiological information to monitor the effect of any corrective measures that you are introducing into the case in order to correct suboptimal physiological results. Something that we have learned some time ago is that physiology is not a surrogate to performing optimization with kissing balloons in two stent techniques. So it's something that is extremely important to remember. And the main use that we use for physiology is, if it is in two stent techniques, it should be done after completing the whole procedure with kissing balloons, etc. Now, we have learned recently, this is a very interesting paper, refers to the left main, but that in cases where you are performing provisional stenting with crossover to LAD from the left main, the residual FFR is actually predictive of long-term outcomes of this very important vessel. And again, this highlights what it was discussed in the presentation of Imad Sheiban, in terms that when you have a vessel that provides such an amount of myocardium like the left circumflex, you really have to optimize your results at a maximum from a physiological standpoint. So let me show you a case that illustrates how we use it in routine practice. You see here this bifurcation that you can anticipate that wiring will be difficult. We are using here a double lumen microcatheter. We struggled for a while with double lumen microcatheter, and then we decided to go with the reverse wiring. As you can see, we are using dynamic coronary roadmap to perform our intervention. You can see that the wire exiting the double lumen microcatheter has been bended backwards like a hairpin. And now we can nicely, as you can see, engage the side branch with the retrograde, with the bended wire, so we can have access to it and perform a proper study. Now, in this case, I must say that I was pretty convinced that we would have to use a two-stent technique, seeing the severity of the stenosis in angiography. But as you know, probably the most important lesson we had from practical perspectives from FFR studies is that you cannot judge stenosis severity based on angiography. And after checking the left anterior descending, the characteristics of the vessel, etc., what we did is we interrogated with IVUS this origin of the diagonal branch, and we were surprised of seeing that there was no plaque whatsoever at that point. So actually, technically speaking, there was no stenosis in the ostium of this diagonal branch. Anyway, we, as mentioned before, at this point, physiology has not a predictive effect on what will happen to this side branch. You can imagine that this carina can easily be displaced. So we move forward and we stented the crossing, the LAD crossing, jailing this diagonal branch. We performed POT. And then after that, we saw, as expected, a very nasty image in angiography in this diagonal branch. We crossed with a wire This speaks about the maneuverability that the wires have nowadays. And then we perform IFR. And IFR, as you can see here, confirmed that actually this was a hemodynamic significant stenosis in the ostium of the diagonal. So this is very important. What we are doing here is we are not taking back the pressure guide wire. We are performing POT before rushing to perform a tap technique or whatever to a stent technique. We try to optimize the result of the intervention with the conventional tools. So we go with a larger balloon to perform POT while leaving the pressure guide wire in place. So we can monitor the effect of this maneuver. And as you will see, this was very useful because immediately after doing this, the value of IFR has increased enormously to the point that we don't have any need to perform treatment. So it's a nice way of showing how you can perform continuous monitoring of the result of your intervention in the side branch by using a pressure guide wire. And then we have completed the case and had a very good result. Of course, always assessing the result with IVUS, not trusting what we see in the angiography. So this is strategy of monitoring your success of different types of interventions. It could be, in this case, an additional POT, or could be also the implantation of a stent using a tap technique is extremely useful. There are some colleagues who have, by default, jailed a pressure guide wire to monitor this. I think that later we can ask Manuel, who is with us. They have some experience also in doing this strategy. Probably in these cases, it will be advantageous to use pressure guide wires that have not a sensor chip, but pressure guide wires that basically have a small hollow wire with the tips, like the fiber optic pressure wires, to avoid entrapment of the sensor. But in any case, it's a very safe maneuver. Other colleagues have been trying other type of approaches. This is an approach trying to use an intracoronary ECG using the wire that is strapped in the that is jailed by the stent in the LAD in this diagonal case. And you can see that actually they found a very nice correlation between an intracoronary EKG showing increase on ST segment elevation and FFR values. So they postulated that probably this is a way of getting some rough information regarding whether you have a problem in the side vessel or not. So what is the evidence that we have regarding the use of physiology during PCI in bifurcation stenosis? Excuse me. So for the time being, we have conclusive evidence of the inability of angiography to depict hemodynamic significance of the gel side branch stenosis. So you cannot trust this type of angiographic image, as you know. Now, regarding the clinical value, we don't have randomized clinical trial evidence that demonstrates superiority of FFR-guided side branch management compared with angiographic guidance. On the other hand, we certainly have objective evidence whenever we're using physiology in this situation on the presence of flow-limiting side branch stenosis. The clinical impact of that will be influenced by a number of factors, like, for example, as it was discussed before, the amount of subtended myocardium to that particular side branch. And these are some of the pioneer studies demonstrating that you can actually monitor the effect of maneuvers like kissing balloon on the hemodynamics of the side branch. There are several reviews that look into this. This is one of our reviews, looking to the previous evidence. But perhaps the most say, important trial that I should mention is the DK Crash 6 trial that demonstrated that there was no benefit in terms of MACE to FFR guidance or angiographic guidance of the side branch PCI. So my personal view, my final slide. Overall, I find very useful intracoronary physiology in planning and guiding PCI bifurcation. I routinely use non-hyperemic indexes, longitudinal vessel analysis, co-registration with angiography, continuous monitoring of side branch pressure to perform decisions based on objective grounds and not looking to angiography. I think that future studies may outline the value of some of these approaches, but for the time being, I encourage you to use this valuable information whenever you consider it may contribute to a better patient outcome. So thank you very much for your attention. Looking forward to your comments.
Thank you very much, Javier. We have several questions from the audience, and we'll take some time. First of all, let me give an opportunity to our panel to make any comments, and then I'll answer a couple of questions from the, present a couple of questions from the audience. The one question which I think is very important is, though pre and post IFR of the significant side branch is more than 0.85, is it necessary to make ostium of the side branch free of struts to avoid future ISR or stent thrombosis? So I think, in other words, do you need to do a kissing inflation if the IFR was more than 0.85 of the side branch?
Well, as I say, we don't have any evidence supporting this attitude at this particular point. And my impression is that I probably will consider I have to do something if I see an abnormal FFR value or an abnormal IFR value. If I know that before I start my PCI, I have already a flow limit stenosis in the side branch. There are no, say, rational arguments to think that performing stenting in the main branch is going to improve that. It can only make it worse. So I think that in that situation, I will be, very proactive in considering that perhaps, that is going to have even a suboptimal result if I use a single stent technique. Now, in the much more frequent situation where I see that FFR values or IFR values are non-ischemic, I'd rather do nothing because I know that some of the colleagues around may have different views. I still believe that it's better not to predilate the side branch, not to cause dissections, and then being able, later on to perform any of the maneuvers I shared with you in my presentation.
One more question and then we'll continue. In the case of POT, at the bifurcation, how do you explain the improvement in the IFR?
Oh, it's very clear. It has been demonstrated in many occasions, in vitro models, and it's quite well known that when you perform POT properly done, positioning the balloon at the right side, etc., you open much more the side branches of your stent, the cells of your stent, and that you perform a plastic deformation of the stent that favors opening of the side branch in many circumstances. So that's the reason because, I really recommend it. It's actually one of the reasons because also crossing to the side branch after performing proper POT also takes place.
One more question. Given that there is a gray zone between 0.9 and 0.93 for IFR, would you rather use FFR instead?
No, I basically, I'm very, as you know, I'm very committed to physiology, but I think that there is a big misunderstanding about the concept of gray zones. Gray zone is something that has little effect on patients. I mean, you rarely see a patient that comes saying, I have a problem, I have a lesion in the gray zone. I think it's a continuous of values, and you have to determine in each particular circumstance, what is the optimal result. If you have a huge diagonal branch, or you have a circumflex vessel, you aim to do as much as possible to get a very good result in terms of FFR or IFR or whatever. But, I personally, in the cases like the ones I shared with you, if I achieve a result where I get an IFR more than 0.89, you know, and an FFR of more than 0.80, etc., I will be pretty happy. I will try to optimize if I think that the vessel is much bigger. But my suggestion to the colleagues that are getting initiated into this, do not get too obsessed about that, because, you know, what you are trying to finish the procedure is without having a flow limiting. This is the point of the study. Don't get too crazy about reaching an FFR of 1, because there are no studies, no rational grounds either to support that.
Any other comments from the panel members?
I have one.
Well, actually,
Javier?
I would like to.
Oh.
Sorry, I would like to underline again what you have showed, that we do not have any support, scientific support, since all studies done comparing angio guidance with FFR guidance are not showing any advantage of FFR guidance in bifurcation lesion. And the second, I think, again, we should go back for the clinical relevance of side branch. If we are speaking about big vessel covering more than 10% of myocardium, I think, yeah, should be optimized every time you are doing angioplasty, because this can affect the prognosis of patient. But again, I am not sure that FFR will resolve this problem.
I fully agree. You know, well, as you know, I'm one of the investigators of the Stent trial, and we have insisted in that the best outcomes of PCI do not come from a single, say, approach. It's a combination of good practices. So I would like to see, you know, a study that focuses, for example, in the left main bifurcation.
That is, yeah.
Combined physiology, using combined intravascular imaging, using combined techniques. And if you put all these things together, is when you are much likely to see a benefit. But it's not coming from a particular thing. If you have a flow limiting lesion, you know, but you don't have a flow limiting lesion, but you have, you know, a malapose stent, it's bad news. So there will be a combination of things. My impression also is that many of the studies, Imad, that we have supporting this, like the studies that I mentioned, DK Crash 6, etc., they were performed in a mixed bag population that does not allow answering the important question of, next time I'm in the left main bifurcation, whatever, should I strive to have a good physiological result?
Yeah, this is the point, the clinical relevance, that it should be included only clinical relevant side branches. I agree, totally agree with you.
Okay. Well, we have a very engaging audience, a ton of questions, but I think that we're going to have to keep eye on the time and like to continue to move the session forward. And it's now my privilege to introduce Dr. Jacek Legutko, a close friend and a long-time faculty of C3 meeting, who is a professor of cardiology at Jagiellonian University in Krakow. He's also been a secretary of Polish Cardiac Society, and he's been a past president of percutaneous cardiovascular intervention of the Polish Cardiac Society, and now he's the head of our department in John Paul II Hospital in Krakow. So great to have you, Jacek. Thank you very much for taking the time to be here. And he's going to talk about IVUS guidance of non-left main bifurcation stenting, when and how to use it in the practice.
Thank you, Raj. Thank you very much for this kind invitation. And of course, many thanks to European Bifurcation Club directors. Intravascular imaging has been shown in this meta-analysis based on the randomized trials effective to improve clinical outcomes of the patients, and not only the total risk of MACE, but separately the lower risk of myocardial infarction, stent thrombosis, and mortality after stenting. However, still in European guidelines, intravascular imaging is indicated only at the level of evidence 2A, and at the same time, there is no specific indication to particular lesion. We only have the indication to use it in selected lesions. How about bifurcations? We have very good consensus document written by experts. And now we see that the IVUS guidance, especially for bifurcations, is indicated in patients with complex lesion morphology, acute coronary syndromes, but in patients with simple lesions, the benefit is not as clear. So it means that for non-left main bifurcations, we should rather focus on complex bifurcation lesions, and especially in those situations that we need to use two-stent strategy. Why is it so? Because in the previously published registries, based on the use of IVUS guidance for provisional stenting strategy, the results are mixed. Some studies were positive, some were negative, but mostly for the total risk of MACE and the risk of reintervention, and not hard endpoints like death of MI or stent thrombosis. There is one study dedicated to the use of IVUS guidance for non-left main bifurcation treatment and the comparison of two-stent strategy. And here you clearly see that using intravascular imaging, you can decrease the risk of stent thrombosis and myocardial infarction. So it means that maybe it's not a big trial, but at least evidence is higher for two-stent strategy than for provisional stenting. This was mentioned many times before, and still I believe is very important. Left circumflex artery as a side branch is usually assessed as a big side branch because it supplies a large territorium of myocardium, like on average it's close to 30%, while diagonals, obtuse marginals, and posterior descending artery, the average myocardium at risk is at the level of 10%. However, we should keep in mind that one side branch is not the same as another, and in this calculation, first big diagonal branch supplied 20% of myocardium, and I believe it's also important to keep in mind when that sometimes our side branches supplies also collaterals, through collaterals, other territory, and this is also the scenario when the side branch is going to be very important. So what does it mean, high risk bifurcation PCI? Of course, it's about complex coronary artery anatomy, and we mostly think about bifurcation lesions Medina 111, but also on those bifurcations with side branch supplying more than 10% of viable myocardium, bifurcation lesion in the last remaining vessel, or when the main vessel or side branch is a donor vessel for collateral circulation. Of course, severe calcifications, this is another morphological feature of complex anatomy. But at the same time, we should also remember that hemodynamic compromise is a very important risk factor for the procedure. So patients with depressed ejection fraction or hemodynamic instability should be treated much more careful, and we should try to always obtain optimal result. And of course, those patients with comorbidities, patients with acute coronary syndromes, advanced age, diabetes. So this is very important to keep in mind all these features. How about the technique of the PCI? Still, we believe that if it is only possible, single stent strategy is the better option. We should try to keep it simple and safe. However, the most important is to understand and respect the original bifurcation anatomy, which is in many patients, and it was previously shown by Javier in his presentation, in many patients, angiography is very misleading, and it is difficult to understand the true anatomy, and especially it is not possible to assess longitudinal plaque distribution across the bifurcation lesion. Of course, we need to optimize the flow and function of a bifurcation following PCI, and the important issue is to limit the number of stents, which should be well opposed and expanded with limited overlap. So how to use intravascular ultrasound in everyday practice? I believe that if we deal with complex anatomy, we should use it in advance, just before stent implantation. There are several important questions we can answer using intravascular ultrasound before stent implantation. We can measure the true lumen and vessel dimensions in the mother and daughter vessel. We can analyze plaque burden, morphology, and longitudinal distribution of the plaque, which is very important to appropriately assess the references and stent landing zone. Stenosis severity and negative remodeling assessment is also important, especially in ostial locations of the stenosis, and measurement of the lesion length is possible. However, it is only possible if you use mechanical probe and automatic pullback. And finally, detection of angiographically silent disease is important. Today, we're talking about non-left main bifurcation, so we will be focused on the diffuse disease in reference segments, which is angiographically silent. Very important stent sizing. We all know that if we implant in advance too big stent in the distal main vessel, then we can create carina shift and we can have a problem with the side branch after stent implantation. If the stent is too small, then we can have a trouble to overexpand it in the proximal part due to stent expansion limits. Of course, appropriate proximal optimization technique is crucial. However, if the balloon used is not optimal, or if the position of the balloon is not optimal, we can have stand-up position and we can have a trouble, especially if we need to rewire to the side branch and to do additional balloon inflations across this implanted stent. Usually we use a visual assessment of angiography. However, it's not very appropriate in many cases, as well as quantitative coronary angiography. The regularly used softwares which are installed in our angio machines are absolutely not appropriate to be used in bifurcations. What we can use is dedicated QCA software, especially 3D softwares, but they are only available or almost only available in core laboratories. So I believe it's not everyday practice to use it. Of course, intravascular imaging has a lot of advantages, and I can say that for many years using intravascular ultrasound to guide my interventions, I am really convinced that there is no other option. If you want to precisely assess what is the true lumen diameter, what is the true vessel diameter, you should use intravascular ultrasound. And very important, especially if we have complex anatomy, is to perform two pullbacks, not only to do the pullback from the main vessel, but if the side branch is involved, if there is also stenosis in the side branch or disease in the side branch, you should always perform the pullback directly from the side branch to the main vessel. Going across the main vessel, across the side branch, we separately assess distal main vessel. We are interested what is the true diameter of the vessel, and we are looking for the good landing zone for the stent with plaque burden less than 50%. Then we are going across this bifurcation and origin of the side branch. We are looking what is the plaque burden and how big is the plaque just in the origin of the side branch. And the same we are doing in the proximal main vessel. And then we assess what happens in the side branch. Do we need to go for a two-stent strategy just since the beginning, or do we have a chance to get a good result just with provisional stenting strategy? As I mentioned, we can also assess the length of the stent, but only if we use a mechanical probe and if we do automated pullback. Pre-interventional lesion assessment with intravascular ultrasound is especially important in calcified lesions, because then we can differentiate if it is superficial or deep calcifications. Deep calcium is usually not a problem for non-compliant balloon predilatations. We are much more careful about the superficial calcium, and if we have superficial calcium, what is the degree of the calcium arc, and if it is more than 270 degrees, we usually assess this lesion as a severe calcification. And this is very practical information, because if we assess what we see on IVUS as a mild calcification, then of course we will prepare the lesion with non-compliant balloons, scoring of cutting balloons. If we have more severe calcium, then we can thing about intravascular lithotripsy. However, still in patients with napkin rings on very severe superficial calcifications, we need to use rotablation or laser to adequately prepare the lesion before stent implantation. And this is the simple case example just to show you how we deal with it in everyday practice. Relatively long lesion, and this long lesion involves also quite large diagonal branch. If we look on angiography, it's very difficult to say where is the good appropriate landing zone for stent implantation, what is the real size of the vessel in the distal and proximal part. If you do one pullback, then everything becomes quite clear. Here, this is the distal main vessel. We can see and we can assess that the distal landing zone for the stent is just in this part of the vessel. Plaque burden is less than 50%, diameter stenosis around 3 millimeters. Then more proximal, you have more severe plaque. And then without significant side branches, we have another spot of the vessel with smaller side branch, with smaller plaque burden, but then the vessel becomes larger and can accommodate larger stent size. It's around 3.6 millimeters. What I said before, you can, if you want to appropriately size the side branch with intravascular imaging, you should go there directly. But if you'd like to predict the risk of occlusion of the side branch during stent implantation in the main vessel, you can measure what is the thickness of atherosclerotic plaque at the junction between main vessel and the side branch. If it is more than 1.3 millimeters, this is the risk factor for side branch occlusion after main vessel stenting. And then we are proceeding with the assessment of the proximal main vessel, proximal to the bifurcation. According to angiography, it looks like as a healthy part of the vessel. However, what's true, you can see that just proximally to the origin of the side branch, still the plaque burden is significantly large, is more than 50%, is at least 70%, and few millimeters before it's still not good enough to position here the proximal edge of the stent, and just few millimeters before you will find appropriate landing zone for your stent. And you can also assess what is the appropriate size for proximal optimization technique balloon, and you can see that this is around 4. So to summarize, only 4 cross sections which will help you how to proceed with the stent implantation in the main vessel. For the distal main vessel, we probably need to use 3/0 stent. It would be sometimes difficult to overexpand and to get acceptable result with 3/0 stent when we need to post-dilate with 4/0. However, in between we have the vessel segment, which is 3.6 in diameter. So my decision was to use 2 drug-eluting stents, 23 millimeter long, overlapping stents. First was 3/0, another one was 23, 3.5 across the origin of the side branch, and I finished this with the proximal optimization and 4/0. How to assess the result of stenting after the procedure? Of course, during the procedure, we can navigate the direct control. We can have a direct control of wire recrossing through the giant side branch. However, this is much better to be performed with OCT. With IVUS, we can assess and optimize stent expansion. We can measure and optimize stent apposition, but also we can assess the full lesion coverage, and we can look for the edge problems, which are the most important and significant risk factors for stent failure, either stent thrombosis or restenosis. Wire recrossing is important. If we use provisional strategy, we want to go across the stent struts distal, across the distal stent struts. If we use, for instance, decay crash technique, we prefer proximal. You can use intravascular imaging, and you can try to navigate if you are going to the side branch through the distal or proximal strut. In this case, it was proximal, and because it was provisional stenting strategy, the wire was repositioned. However, with intravascular imaging, I don't believe it's It's very predictable, and personally, I don't use it in everyday practice anymore. And the most important role of IVUS is to check for the result. And as we all know, the most important risk factors for stent thrombosis and stenosis are still the same. So stent underexpansion and edge problems. So if we assess the result, we need to look for edge dissections, and not every edge dissection is important and has to be treated. We are usually focused on those edge dissections with the flap, which is more than 60 degrees of the cross section. If the flap is going very deep to the media or adventitia, of course, if there is the dissection which is more than 2 millimeters in length, then important is not to leave the edge of the stent in the residual plaque burden more than 50%. This is what I discussed before. It's very unfavorable, especially if you have a stent malposition in the proximal main vessel, especially if you need to rewire. So it's very important to check for this and to correct with bigger balloon or higher pressure. Of course, if you see the prolapse on angio, and sometimes you don't see, then with intravascular imaging, you can quantitatively check how big is this flap, and if it is just plaque protrusion or if it is thrombus. And finally, of course, you need to look for stent under expansion. It's very important to stress that usually we do it just looking on the screen qualitatively. However, the most important is to go just and to measure what is the real stent expansion. This is the result of the stenting of the patient that I previously shown. So on angiographic, beautiful result. However, your probe is on the table, and you should always check with intravascular ultrasound what is the result. And qualitatively, it looks very nice. We have the proximal edge of the stent, which is positioned in the segment of the vessel with small plaque burden, less than 50%. The same is true for the distal vessel. You see that the stent is well expanded. However, here it's this D shape, and we clearly see that the stent is a little bit under expanded. It's very important to say that if you are checking the result of the treatment of bifurcation lesion, then stent expansion has to be assessed separately for the distal main vessel. And in this patient, as you see, even if it doesn't look perfectly, we have some oval shape. However, if you measure the minimum lumen cross-sectional area within the stent, and if you compare to the distal reference lumen area, the stent expansion is 91%, so it's very good result. And the same was true for the proximal main vessel, where the stent expansion was close to 100. And at the end, if you use two-stent strategy, everything what I said is true, except of the fact that if you implanted additional stent in the side branch, then afterwards you need to go there with your IVUS probe to check what is the result of the stenting, and you do the same measurements. Of course, you need to assess the minimum in-stent area and to compare this to the reference lumen area of the side branch. So to summarize my talk, these are my take-home messages. Better insight into plaque configuration with intravascular ultrasound can diminish the unnecessary use of the two-stent procedure by distinguishing true stenosis from pseudostenosis caused by artifacts, including coronary spasm or calcification in the side branch. And it can also facilitate decision-making on stenting strategy in patients with ostial stenosis in the distal main vessel or in the side branch. Intravascular ultrasound evaluation of stent expansion, apposition, and edge problems is absolutely superior to angiographic assessment. IVUS guidance may reduce the risk of death, MI, TVR, and stent thrombosis after PCI with drug-eluting stents compared with conventional angiographic guidance, especially in high-risk lesions. So the use of IVUS guidance for stent optimization may be beneficial, especially for complex bifurcations, i.e. those with Medina 111. Two-stent technique when it is used, bifurcations with severe calcifications, those in last remaining vessel or the donor vessel for collateral circulation. So thank you very much for your attention, and I'm open to answer the questions.
Great. Thank you so much, Jacek. It was a great presentation. First question from the audience is, what is more relevant for a quick decision, MLA or plaque burden?
MLA is important if you have problems to assess the lesion severity, and it is much more important for assessment of the left main lesion, because in non-left main lesions we have not good cutoffs. However, in pre-procedural planning, I believe much more important is to assess plaque burden, especially if you want to define appropriate references. And then after the procedure, of course, the minimum in-stent area, then it is not MLA, but MSA, so minimum stent area is important to compare with the reference lumen area and to assess stent expansion.
The second question is there an acceptable distance between stent and a vessel wall to determine safe apposition by IVUS? Or is it a visual judgment call?
Usually we say that if it is, the distance between the stent struts and the vessel wall should be no more than 0.4, but it is very difficult to assess by intravascular ultrasound. It's better with OCT, and I believe it would be covered in a second by the next speaker. However, I believe that it is also important to stress that if you have one or two stent struts which are not absolutely opposed to the vessel wall, it's not a problem. The problem is if the stent malapposition occupies the longer segment of the vessel.
Is it necessary to routinely perform IVUS in all left main bifurcation PCI?
I believe it would be very interesting discussion in 2 weeks ahead. In my personal opinion and my personal approach, and I do more than 100 left main PCIs each year, I use IVUS in all cases, and including those with cardiogenic shock. However, it is still ongoing debate, and I would be very happy to know the opinion of Yves, because he is probably against, and still at PCR seminars we debate this with Thierry Lefebvre and with Jean Fajade. It's open questions. However, when I ask all those guys to perform randomized trials, they say it's unethical because it would be not possible to ask the people to use a control group with angio guidance only, and it would be a lot of crossovers.
So, may I answer this?
Yes, please. Yeah.
Yeah. So, I don't tell that it's not useful to do, or even not important to do in all patients an IVUS or an OCT in the left main. What I tell is we don't have today a randomized trial convincing that help our government to reimburse, to have a systematic analysis with OCT and IVUS. And I think this is very important, at least for this reason. This is not a scientific reason. Yeah. If I use my budget with to use systematic 100% of left main with IVUS or OCT guidance, then I will have not enough money to do some valve in poor patient not able to pay, or in foreign people, or I don't know. So I think we need a randomized trial. People are producing analysis from big database, huge database. We know that it's still possible that there are some bias, and it's necessary to do a randomized trial. Personally, I'm sure and convinced that my group, Thierry Lefebvre and others, will accept this randomized trial without any problem.
Yeah, it would be difficult for us to accept, but I need also to, I have some conflict of interest stating this, because we have in Poland full reimbursement for IVUS, and we can use it in left main PCI in either elective and acute cases, so there is no economical issues to do that. And if you do, it's important to stress that it's safe, because sometimes people tell that they do, cardiogenic shock stenting in left main, and they did, and especially in those patients, it's important to check because vessels are spastic, and I've seen a lot of patients with, 3 or 3-5 stent in the left main, which is horrible. So I believe that this is very safe to do intravascular ultrasound. You don't need to inject the contrast. It takes like 1 or 2 minutes, and you are not able to harm patient using intravascular imaging in those cases, but you can only, improve the result and improve the outcome.
Well, thank you very much for that great discussion, great talk, Jacek. Thank you so much. We'll continue with the program now. It's now my privilege to introduce my close friend, Dr. Yoshinobu Murasato, who's been a scientific organizer of C3 for almost a decade and a half. He's a professor of medicine at Kyushu Medical Center in Fukuoka, Japan, and has been a worldwide speaker on the bifurcation topic, very famous, including has a book which was given to the fellows at C3 Congress several years ago that he authored with a few other physicians regarding bifurcation techniques and some bench testing of bifurcation. He's now going to talk about OCT guidance of a non-left main bifurcation stenting, when and how to use it in the practice. Dr. Murasato.
Thank you, Rajesh. It is a great honor for me to attend the C3 and the EBC collaborative meeting. And my topic is the OCT guidance of non-left main bifurcation stenting. This is my disclosure slide. And a previous speaker presented the same slide. A general concept of under the intracoronary imaging guidance, the stent should be located at the site plaque burden less than 50% at the stent edge and no repeatable or dissected site. And stent should be diminished malabsorption less than 0.4 millimeter in axial distance, and minimum stent area should be larger than 4.5 millimeters square in the OCT guidance. And stent expansion index is hopefully more than 80%. According to the higher resolution of the OCT has an advantage to detect the repeatable dissection and malabsorption and protrusion. And this slide showed this study shows the impact of the OCT guidance over angio-guided strategy. Pre-intervention OCT changed the strategy in 82%, mainly because lesion length and stent diameter. And post-intervention OCT also changed strategy in the 55%, mainly because the stent malposition and the stent edge dissection and under expansion. Serial OPCA study is a randomized trial compared to the angio guidance and the OCT guidance for the intervention. And composite endpoint of the cardiac death and marked infraction, the OCT usage decreased this endpoint. Hazard ratio is to be 0.44. Recent innovation of the OCT is a 3D reconstruction, which can demonstrate the accurate guidewire recrossing point and strut coverage, gelling strut pattern. We conducted the 3D OCT bifurcation registry in Japan, and we revealed the effect of link connection on remain gel struts after Kiss-and-Barrel inflation. We developed the two types according to the existence of the link connection at the carina site, link free carina type, and connecting to carina type like this. And once in the link free type, the guide wire crosses the distal side and distal side, optimal side, we can obtain the side branch optimal side branch dilation largely. And however, in the connecting to carinotype, even after distal wiring, link connection still remained at the side branch ostium. And we investigate the incomplete thread apposition after Kiss-Barlow infiltration, and we compare the two type, link-free type and the distal wiring type, LFT type, and a non-LFT type. And here you can see incomplete stent apposition after at the bifurcation bifurcated side. LFT type has less incomplete stent apposition. And we also investigate the success rate of the optimal guidewire recrossing. First attempt, which means the angio-guided guidewire recrossing, the success rate is only 66%, accumulating the 3D OCT guided guide wiring. The success rate is elevated. It's to be around 90%. And we should know the abnormal guide wire recrossing to the side branch has a significant effect on the stent deformation. We cannot differentiate the 2 points, the yellow point and the red point. Yellow point means the distal side with the distal cell, and the red point is a proximal side of far distal cell. Far distal cell means 90% of the body embedded in the distal member cell. And this is a bench testing. We investigate the current 4 type of the DES. Here you can see during the side branch dilation, distal member cell strut extended to the direction of the side branch like this. A similar finding is found in the actual clinical case. This is a resolute stent crossover to the side branch. Guide wire crosses the far distal cell here. And after final Kiss-Barlow infiltration, here you can see a distal member cell strut extended to the side branch like this. This kind of the dispersed strut at the branch ostium may lead to the dystonic reaction at the side branch. And this is another case. The guide wire recrossing on the 9 o'clock and the 2D OCT images. The guide wire recrossing to the side branch at somewhat lateral side for the side branch. However, we cannot understand where the guide wire recrossing accurately. However, 3D OCT reconstruction clearly demonstrated that guide wire recrosses in the side branch in the proximal cell. So this guide wire recrossing is a suboptimal space. However, at that time, we skipped the 3D OCT reconstruction, so we dilate the proximal cell with the side branch dilation, and finally, POT was performed. After the procedure, we surprised the 3D reconstruction images. Here you can see 2 overlapped struts at the cardiac side. The mechanism is the following. Side dilation in the proximal cell, and adjacent cell was protruded into the member cell lumen. And the final POT caused a turn back of the protruded strut in the inverse the direction. And some doctor has a serious concern, the increase of the contrast medium in the OCT guided bifurcation intervention. Here you can see this long left LED region has some bifurcation region. In this region, we compare the image quality of OCT, regular dose of contrast medium, small amount of the contrast medium, and the low molecular dextran in subsidized with the contrast medium. Here you can see there is no difference in the image quality of OCT. Our Japanese colleague, Dr. Kurogi, investigates the efficacy of the dextran used for OCT guidance. And they compare OCT guidance and the IVUS guidance. They divide it to the 3 groups according to the renal function. Here you can see there is no significant difference in terms of contrast volume between the OCT guidance and the IVUS guidance. And they also investigate the effect on the renal function, creatine level, and the EGFR level. Here you can see there is no significant difference before and after PCI in OCT guidance, and there is no significant difference IVUS guidance and OCT guidance. Therefore, OCT usage for OCT guidance usage of dextran is safe procedure and does not have significant impact on renal function. And another concern is the difficulty in image acquisition in alt-ostial area, left main, ulcer ostium, and LD ostium. This is a region of the LD ostial region with large left main. In such case, we sometimes try to get the good imaging for this region. In such region, we use a see-through technique using a special guiding catheter, guided extension catheter. Telescope is the best one because inside the guided extension catheter, infrared light can penetrate through the catheter. So we can observe the vessel. This is the actual images. We insert the telescope in the left main. Here you can see the calcified region and LD ostial region. Through the tip, we can observe the left main, and telescope body has a helical coil. Between the coil, we can see the left main clearly. And OCT has an advantage for the clear visualization for the calcified region. The calcified bifurcation region, you know, this is the allowance for the interventionist because the calcified region has a potent predictor for the stent malapposition. And in non-true bifurcation region, cardiac displacement is likely to occur. In true bifurcation region, less stent expansion is likely to occur in both members and side branch.
Dr. Murasato, there is some comments from the audience about your audio is not coming out very clear. May I request you to speak a little louder so that we can overcome the disturbance in the web traffic?
Okay, speaker loud. Okay. Can you hear me?
That's perfect. That's perfect.
Yeah. Okay. Recently, OCT based calcium scoring is proposed. A maximum calcium angle more than 180 degrees, a maximum calcium thickness more than 0.5 millimeter, calcium length is more than 5.0 millimeter, and the more points indicate the usage of the rotational or orbital atherectomy. And side branch occlusion after bifurcation intervention would lead to the worst clinical outcome compared to the non-side branch occlusion. Prediction of the side branch occlusion before intervention is crucial for the bifurcation intervention. These factors are proposed as a predictor for the side branch occlusion in OCT analysis. Cardiac tip angle less than 51 degrees, not bifurcation angle. And bifurcation point and tip length less than 1.75 millimeter. That means the short, long cardiac tip has a risk for the side branch occlusion. In another report, maximal lipid arc in member cell and contralateral location of lipid plaque in the member cell is a risk for the side branch occlusion. And German technique is useful to prevent side branch occlusion. This is the LD diagonal 111 region. We use the modified German technique, which means this, simultaneous ballooning in the side branch and member stent. Under the guidance of OCT, we try to cross the guideway to the side branch for the final kiss and balloon inflation. This is the first try. Here you can see OCT indicates the malar opposite strut and red color. And first guideway recross here. This is a static image. Guideway recross here, lateral to the side branch. So this is a suboptimal guideway recrossing. We try again. The second try, guideway recross here, more proximal side. So the guideway recrosses here. So this is also suboptimal. So we perform the pod and recrosses the side branch and guideway recross optimal space. And we confirm the fly through view. Left guide wire is the side branch one. And we confirm this is the current side. The side branch guide wire recrosses the distal cell. So we directed this cell. And post-dilation for stent and expansion is crucial for bifurcation intervention. However, element 3 demonstrates a higher prevalence of the stent and expansion that reached to the 60%. One of the reasons is the stent expansion index is designed for the refer to the distal and proximal reference. So Nobel OCT software has proposed a newly proposed the volumetric analysis obtained by creating an ideal lumen profile considering vessel tapering and branching using focus model minimum expansion index. That means that branching point newly smaller difference was set in the distal side. This is the actual clinical case. Here you can see this is the LED region, the bifurcation region located here and here, two bifurcated points. So the difference set the proximal side, middle side, distal side, three difference the OCT software set. And minimum stent area is located the distal side here. Lumen area is 3.4 millimeter square. It seems to the suboptimal. However, expansion index is 89%. This is satisfactory. However, minimum expansion index is located the middle side, 67% here. Lumen area is 4.4 millimeter square. It seems to the optimal. However, considering the natural vascular branching vessels, according to the natural branching vessel law, the post-ballooning target should be changed from the minimum stent area to the minimum expansion index. Ladies and gentlemen, this is my summary slide. When and how to use OCT guidance in bifurcation PCI. Procedural OCT, lesion, we should check the lesion characteristic. It is useful to stratification of lesion preparation and necessity of Sheiban treatment and the decision of the device size, length, landing zone. And the procedure, lesion preparation, stent expansion, and port and guideway recross. We strongly recommend the post-stenting OCT and the guidance with 3D reconstruction for the assessment of the guideway recrossing point and the jailing strut pattern at the sideband ostium. After confirmation of the optimal guideway recrossing, final kiss and balloon inflation or sideband dilation was performed and the report was followed. And post-procedure OCT should be done to check stent failure, edge dissection, sideband jailing strut, and carina safe. Another tip is the use of the dextran to decrease the contrast medium and guide extensor catheter for good image acquisition. Thank you for your attention.
Thank you very much, Dr. Murasato. Many questions on OCT already today. In how many percentage of bifurcation cases in your institution that you use OCT for?
In the bifurcation, our lab, 60 to 70% we use OCT guidance. The rest is IVUS guidance.
Yeah, you know, that's, you know, a little bit more than what we do. We have about 50% penetration of OCT in our lab. Another question is, do you use the saline or other than contrast for OCT imaging?
Mainly use the dextran. So maybe first shot we use the contrast medium to get the angio co-registration, to make the angio co-registration. However, most of the observation we use dextran. So some American doctor has a serious concern. Dextran has a serious effect on the renal function. However, Japanese colleague clearly demonstrates no effect on the renal function. So average usage of the contrast medium is less than 100 milliliter. So small amount of the contrast dextran does not have a significant effect on the renal function.
Any other comments from the panel members and the directors?
I have
Yes,
one.
Raj, I have a comment, if I may.
Sure.
I like very much the images you show about the use of the extension guiding catheter, the telescope, for optimizing injections. Of course, I mean, making injections through extension guiding catheter into the coronary arteries has always associated some small risks. Can you comment about how you ensure safety when performing such selective injections into a specific vessel, into the LAD, for example?
It's a very good question. So inserting the telescope in the left domain, not to engage the LED or SX selectively, because the flash with some pressure make the spiral dissection into this side. So not to engage the branch of LED or SX directly. Very close to the ostium. That is the point. And some the flashing contrast medium or the dextran can flash out the red blood cell in the left main.
But basically, just for the colleagues that are joining, the distinct advantage is that you can image the ostium because you show us that it is transparent to light. Is that correct? I mean, typically you cannot explore the ostium of the left main because of non-selective flashing, so to speak, with contrast. But with this, you can image. Is that correct?
So when we use the dextran, we use a manual injection. So we can feel the pressure. So that is the reason for the avoidance of the spiral dissection in the left main or this side. So I recommend the manual injection for such case.
Thank you.
Well,
I have a question too.
Yeah, please go ahead.
This is for Yoshi. I like very much your idea of using OCT to rebuild a functional anatomy of the bifurcation. I think this is something we consider as interesting to do, to give the bifurcation we are treating the good anatomy. And I don't think, and this is for Jacek, I think the situation of OCT for this is different from the IVUS. Because in the IVUS, you are choosing your stent on the media to media. And we know that in some lesions, you may have positive remodeling that gives a single diameter from proximal main to distal main. So can you comment that? And also, Yoshi, do you plan to have a kind of validation of this?
We can imagine the better size from the normal side. In the normal side, we can evaluate the media to media, even in the OCT. We cannot evaluate the positive remodeling site, as you mentioned. However, we can observe the normal-like side in the proximal side and distal side, so we can imagine the normal vessel size in the bifurcated side. So the new OCT software, estimate such kind of ideal reference according to the branching law. So the proximal side and the distal side and the side branch size ideal reference. So that is the advantage in the OCT analysis for the bifurcation intervention.
Thank you.
Your question is appropriate because with IVUS we can see the also when in the plug area usually we can differentiate media and we can appropriately measure true vessel size, which is in contrast to OCT. However, in this positively remodeled segment of the vessel, I would not recommend to use in all cases media to media diameter. Usually I go just halfway between lumen and media diameter. Otherwise, you can expand your the risk of vessel rupture increases, especially with this calcified vessel.
Yeah, I totally agree with you. So reconstruction, the natural size is very important, even in the possible remodeling side.
Okay, thank you very much, Yoshi. Fantastic presentation. It's now my privilege to introduce our keynote speaker from last year of C3 meeting, as well as Lifetime Career Achievement Award winner, Dr. Yves Louvard, who's been a founding member of European Bifurcation Club and professor of emeritus professor of cardiology from ICPS in Paris, France. He will discuss now how to deal with the difficult side branch access, stent selection, and strategies for rescuing compromised side branch. I'm sorry, I was my mistake. I presented Dr. Louvard, but this presentation will be done by Dr. Sike Chan. Dr. Sike Chan is a great friend and honorary consultant cardiologist at United Christian Hospital in Hong Kong, and has been a faculty member of C3 for many years, and has spoken many times at the Asia Bifurcation Club. He'll do this presentation. I apologize for that.
Not a problem. So thank you, Dr. Javi, for the very kind invitation to join this meeting. This virtual meeting is a whole new idea for me, and I love to see you all here in a web-based manner. So my job today is to talk about how to deal with difficult side branch access in terms of stent selection and strategies for rescuing compromised side branch. So for this presentation, I do not have anything to declare. So when you look at bifurcations, they all look similar, but then they all behave very differently. So a lot of us have talked about the use of different classifications to look at bifurcation lesions. One of the commonly used bifurcation classification system is the Medina. So if you look at the Medina's classification, true bifurcation lesions are defined as having 111, 101, and 011 distribution. Now, having said that, the Medina's classification or other simple classification probably is not very good. They are good for daily communication and they are commonly used for the conduction of clinical trials. However, how accurate is it in terms of predicting side branch closure and therefore the need for a planned two-stent approach? So if there are other factors that potentially can affect the chance of side branch closure, if you look at the bifurcation more closely, then perhaps the degree of narrowing would also be very important. For obvious reason, if you have more severe osteo disease, the chance of losing a side branch would be higher. The extent of plaque burden, eccentric distribution of the plaque, very diffuse disease extending from the side branch ostium, probably talking about 5 or even 10 millimeter of disease, significant calcification or tortuosity. Now, shallow angle bifurcation between the distal branches is actually a risk factor for closing the side branch. But having said that, in fact, if you have a very wide angle bifurcation, like more than 100 degrees, then it's also a predictor of closing the side branch. Of course, if the case is having an impaired flow at the baseline, that would also affect the chance of side branch closure. So there are a number of other important risk factors or angiographic features that we need to look at, apart from just simply looking at the degree of involvement in the proximal parent vessel distal branches. So to address this problem, perhaps a newer classification system is required to look at what we call complex or true complex bifurcation. Now, this is the definition 2 trial that has also been mentioned by previous speakers. So in this trial, definition 2 try to define true complex bifurcation as having 1 major or 2 minor criteria. If you look at non-left-wing bifurcation, then side branch lesion length has to be more than 10 millimeter, and the side branch diameter stenosis has to be more than 90%. So very difficult bifurcation lesions. And then you also have 2 additional minor criteria, including the presence of calcification, multiple lesions, very extreme narrowed or wide angle bifurcation, main vessel reference diameter less than 2.5, main vessel disease extends more than 25 millimeters, or thrombus containing lesions. So if you look at this trial that has recently published, if we are treating truly complicated bifurcated lesions, then perhaps the use of planned 2-stent approach is actually better than provisional single stent. This is translated into a better 1-year outcome in terms of target lesion revascularization, target vessel MI, or target lesion failure. So to answer the first part of the question would be whether stent selection is really a huge issue when we are treating complex bifurcation. In my opinion, stent selection probably is not the main issue. I think the most important thing would be to identify the complex lesions and therefore a higher risk of closing the side branch. And in such situation, we should not be shy away from using planned 2-stent technique. However, if we are going to use 2-stent technique, there is a need to follow the steps very meticulously. And also, we need to use the correct contemporary techniques, including, for example, the use of intravascular imaging, whether you are using intravascular ultrasound or OCT, a properly performed POTS technique, and also we have to pay attention specifically to where we are exactly crossing into the side branch. So many important steps that we need to follow. Now, in the second part of my presentation, I'd like to focus more on the technical tips in terms of saving a compromised side branch. One of the common questions that I get asked from my fellow would be, oh, should I send a wire down a side branch for protection? My simple answer would be yes, because if you feel that this is a clinically important side branch, I don't think we should spare a moment to avoid sending a wire down. And the reason is, having a wire down probably will save you a lot more time. Now, for example, if you look at this relatively simple bifurcation without much disease at the side branch ostium of the diagonal. So pre-dilation followed by provisional single stent, and you can see complete closure of the side branch. Now, by the end of the day, we are able to rewire into the side branch and conclude the procedure, but then we spend extra time on this. So the advantage of having a jailed side branch wire is that it serves as a marker for rewiring in case there is acute closure of the side branch. either due to dissection, hematoma, plaque, or carina shift. Now, having a guide wire down the side branch also helps to modify the angle of the bifurcation in a way that sometimes it would also facilitate another wire recrossing. Now, having another side branch down there also gives us the options to switch to other techniques, for example, the side branch balloon technique or the rescue inverse crush. Nowadays, we talk a lot about the use of POTS technique. So the idea is that when we size the stent, we try to size the stent according to the reference diameter of the main vessel, the distal main vessel. So the proximal main vessel would always be bigger than the side branch. So using the POTS technique, we are able to fully oppose the stent strut so that recrossing into the side branch would be easier. The chance of getting the wire under the strut would be lower. And also by doing a proper POTS, we expand the size of the stent cell so that rewiring into the side branch is also more easier. However, it's important to pay attention to how we actually properly perform the POTS technique. In this picture or animation, you can see that if we position the POTS balloon too far away from the carina, then we are not doing the job. If we position the balloon too distal to the carina, again, we are not doing the job. So the idea is that we have to position the balloon at the correct position. So what we need to do is to align the shoulder of the balloon right at the carina of the bifurcation. So this is an animation showing you how a properly performed POTS technique and can improve the way we recross into the side branch. So this is without POTS technique. You see how the wire is very difficult to get into the side branch. Whereas, if you do a proper POTS by opening up the stent cell, then rewiring using this wire switch technique would be much more easier. So nowadays we perform a lot of POTS technique, but I'm sure when you do the POTS technique, you would experience sometimes acute closure of the side branch because the balloon pushing the plaque towards the side branch ostium. So again, we have a benefit of having a wire down the side branch. So look at this case example where you see this is a distal left main bifurcation lesion. And the plan was to have provisional standing. After pre-dilation, a stand is put from left main into the LAD and then followed by POTS at the left main. So now you see complete jailing of a very important big side branch, the circumflex. And of course, the patient would be unhappy. The hemodynamic condition would be unstable. So of course, one of the trick would be to use the jailed guide wire as the marker, and you try to rewire using a third guide wire. However, in the case when the patient is very unstable, sometimes we do have to do the job fast. So one of the way is to slip a small balloon under the stent so that we can dilate into the jailed side branch. Now, to do this, it's very important that we park another balloon in the main vessel, because by getting another balloon under the strut, we can distort the anatomy of the proximal stent. So we need to prepare to get a balloon in the main vessel before we do this procedure. So having this in place, then we can have different options. You can convert this into a mini crush, or if there is a need to, you can also do an inverted crush. So that means instead of using this as the side branch, now we put a stand and use this as the main branch and crush this original so-called main branch. We also use a lot of the double lumen catheters for wiring into side branch with very difficult angles. So commonly used double lumen catheters include the use of Crusade, Trinpass, and or Sasuke. So essentially, this is a microcatheter with both an over-the-wire lumen and a rapid exchange lumen. Now look at this case example where you see a rather complex LAD diagonal bifurcation. I put this into still pictures. The LAD ostium is very critically narrow, so that the TIMI flow is impaired as well. So we tried a different number of wires as well as different angle shaping. Again, we were unable to get into this LAD. So eventually, with the help of a dual lumen catheter, we are able to get the wire into the LAD. And the thing to remember would be when you try to remove the double lumen catheter, an easier way to do would be use the trapping balloon technique. Otherwise, you would have to extend the guide wire, and you run the risk of losing wire access into both side branches. And the procedure can be completed now with a simple single stent. And this is a very satisfactory result, I would say. Now, in terms of wiring difficult side branch, actually, the use of CTO wire technique is also very helpful. Now, take a look at this case example where you get a rather tricky lesion at the mid-pulse at the bifurcation point of the acute marginal branch. So we send a wire into the acute marginal, and then we try wiring using a microcatheter and on the wire. So you can see that the best view actually to lay out this bifurcation lesion is the true lateral 90-degree angle. You see this wire is not actually getting into the true lumen. It's actually in the subintimal space. So we try not to push the wire forward. We leave this wire as the buddy wire or parallel wire. And now we get another microcatheter and start wiring using this, probably is the Fielder XT wire. So you can now see that with the original wire being parked in the subintimal space, we are not losing access, and it serves as a marker to allow the second wire to go for a different position. So this essentially is a CTO wire technique, and the procedure can then be completed smoothly. Now, sometimes wiring can be very, very difficult, as you can see in this particular case example. I put this into a still picture for you to appreciate. You can see that there is a significant degree of vessel overlapping, but we try to take projection from different angles, but then there is still always overlapping vessels. We are unclear about the exact origin or takeoff of the LAD. And the takeoff ending of the LAD is also very acute. So to overcome this procedure, we think about the use of the flexible tip microcatheter. This is the venture catheter that was used to be manufactured by St. Jude Medical. I would say, however, this deflectable tip microcatheter sometimes it's quite hard to use because it's a bit hard to control the direction of the catheter tip. So one of the other options would be to use this angled or curved tip microcatheter. So this is the supercross microcatheter family that comes with different angles of 45 degree, 90 degree, or 180 degree. Now I show you an example. This is an LAD diagonal bifurcation, very tight at the osteo LAD here. This is the diagonal branch, and this is the LAD branch. So it's very, very hard, extremely hard to get directly into the LAD. So what we do is we try this 90 degrees supercross. So why actually, for some reason, get into the diagonal rather easily? So first we deliver the wire into the diagonal, and then we advance the supercross across the bifurcation point. Then we withdraw the wire and come back on this supercross. So you can see the tip of the supercross is engaging very nicely and pointing towards the direction of the LAD. And next, we can easily send the wire into the LAD. So with the use of angle-shaped microcatheter, sometimes we can wire these very difficult side branch angles. And of course, the procedure can then be completed rather easily with a single stent. One of the previous speaker has already talked about this reverse wire technique. Now, this is the reverse wire technique originally described by Kawasaki more than 10 years ago. So this is how he insert the Fielder FC, which is being curved into double curve in the reverse direction. And this is how he introduced the wire system through the guiding catheter directly. Now, this has a problem because if you introduce this directly into the guiding catheter, it is actually quite hard to introduce the wire into the target vessel. So a modified way to do this is to make use of a double lumen catheter, for example, the Crusade microcatheter. So first you put a regular tip curve at the wire, and then you put a second curve in the reverse direction. Usually this will be about 30 millimeter or so. So I like to use slippery wire, the polymer jacketed wire, to do this. And then you put this double curved wire through over the wire lumen of the double lumen catheter. So the whole thing will then be advanced, unblocked through the Y piece of the system. So this is another wire that has already crossed into one of the side branch. So to put this in a clearer schematic way, this is how we do it. So you get the wire down one of the branch. Now you push this assembled double lumen catheter with the double curved wire all together. So you get the system across the bifurcation, and then you come back on the double lumen catheter. And the next thing would be to pull back on the double curved wire. So sometimes you need a little bit of adjustment to get the tip of the wire pointing into your side branch. So by coming back on the wire system, somehow the curve of the wire would allow you to get into the side branch. Okay. So the use of double lumen catheter has made this Kawasaki technique much easier. So again, I like to show you just one more case example. This is a rather difficult takeoff angle of the LAD. So this is the way how you need to curve the wire in order to get into the LAD. So we try a number of times using different wire shapes and different wires, but unfortunately, the wire almost always prolapse into the diagonal. So the best goal will be this one, but then the wire upon pushing still prolapse into the diagonal. So first we would use a small balloon to dilate into the side branch. So this facilitates the passage of this double lumen catheter. This time I used the BT2 wire, which again is a polymer jacketed wire. So the double curved wire is pushed across the bifurcation. And then we come back on the double lumen catheter, leaving behind the double curved wire forward. So you can see how the tip of the double lumen catheter engaged into this LAD. Okay, so you see how it gets nicely into the LAD. And of course, the rest of the procedure would be very standard, and we are able to treat this very difficult angled bifurcation. So on this note, I'd like to stop my presentation and would like to welcome any questions. Thank you again for allowing me to present at this very special occasion.
Great, Dr. Sikachan. That was a fantastic presentation on how to deal with the difficult side branch access. Any comments from panel members?
Okay. May I?
Yes, please.
Thank you. Thanks for the presentation of our case of the TCT with inverted crash. For this difficult technique, do you recommend some special microcatheter or low-profile balloons or some tricks to access the side branch? Also, it's important to do or not to do the pot before the access, because if you perform a very aggressive pot, this made difficult the technique to access to the side branch through the abdominal wire.
Yes, thank you, Dr. Pan, for your question. So sometimes, it's difficult. If we do not perform aggressive POTS, then we leave behind stent struts that are not fully opposed. And then there will be a chance of wiring under the strut. If you perform very aggressive POTS, then we run the risk of jailing the side branch. So I would say I tend not to do very aggressive POTS. I do a POT and then I check the flow into the side branch. If it's already compromised, then of course there would be no need to do another higher pressure inflation. Regarding the technique of the side branch balloon, so as I stress, I always put another balloon into the main branch. So, and then I use the smallest size balloon, a smallest size balloon. Usually, the smallest size one that is available nowadays would be the 1 millimeter balloon. So it's a very small. It has a very small profile. So I would slip this 1 millimeter balloon through the stand strut. Sometimes this can still be a bit difficult because after POTS, it's very hard to slip a balloon inside. So the next thing to do would be to inflate the balloon into the main branch to serve as an anchor. So having an anchor balloon down the distal branch of the main vessel that can improve the backup support to allow me to send in this small balloon. So this would take a little bit of time. So it's also important to remember that after we slip in a small size balloon, we are going to disrupt the anatomy or structure of the proximal main vessel, and that has to be corrected at a later stage as well.
Thank you.
Thank you.
Great. That was fabulous. Let's continue to move forward. Thank you very much, Dr. Chang from Hong Kong. I know it's late in Hong Kong, and I really appreciate you taking the time at a very late evening to be with us and give us some pearls of side branch access. So now we'll move on to, thank you. Part 2 of the techniques. The moderators of this session will be Dr. Yves, Louvard, Dr. Manuel Pan, Dr. Azeem Latib, Goran Stankovic, Dr. Murasato, and Niels Holm. And it's a pleasure again to introduce Dr. Murasato on speaking on his favorite topic, kissing balloon inflation, when and how to do.
Kissing balloon, okay. Thank you, Rajesh. My talk is a kissing balloon inflation. This is my disclosure slide. And firstly, I would like to ask the audience, what is the purpose of the kissing balloon inflation? We used to expect the following role for the kissing balloon inflation in the proximal main vessel: large stent expansion, decrease in stent malposition, prevention of stent deformation induced by side branch dilation. In the bifurcation, prevention of cardiac theft, and in the side branch, removal of the J struts and the optimal size dilation. And we recently recognized there is a difference in the efficacy of the kissing balloon inflation between 1 stent and 2 stent. Well, however, there is no clear evidence, for why this difference occurred in the kissing balloon inflation. So I would like to share the 2 parts of this session. First part is the efficacy of the kissing balloon inflation on a 1 stent technique. Recent meta-analysis clearly demonstrated there are no advantage in the final kissing balloon inflation on the major adverse cardiac event related to the main vessel events, such as stent thrombosis, myocardial infarction, and the target vessel revascularization. However, this meta-analysis clearly demonstrates that final kissing balloon inflation increases the main vessel resonances, but decreases the side branch resonances. Therefore, final kissing balloon inflation increases the main vessel-related adverse events. These are the following possible mechanism for this. the damage of the polymer of DS by complex procedure, non-uniform deformation of the members stent, excess metal overlap or dispersed strut due to inappropriate guideway recrossing, and edge dissection due to overexpansion. We invested the effect of the kissing balloon inflation on member stent shape in the J-reverse trial, which enrolls the 300 non-left main bifurcation intervention under the guidance, IVUS guidance. We investigate the 1 minute stress analysis in the, around the bifurcation. Here you can see a kissing balloon inflation promote the elliptical stent deformation in the proximal side. However, kissing balloon inflation provides a large stent expansion in the proximal side compared to the distal member cell by 30% enlargement. This bench testing performed the 6 independent operators. Here you can see various configuration of the proximal member stent was shown. And the position of the side branch is decided dependent on the operator's decision, and various configuration of the balloon overlapping style was shown. Therefore, standardization of the kissing balloon inflation is very difficult. In addition, proximal overlapping side shows the bottleneck shape stent deformation. This is the actual clinical case. Treated with a long overlapping kissing balloon inflation with egg shape. This is the IVUS images. Here you can see a minimum stent area located the LD ostium area, which is the most luminal narrowing before intervention side. And proximal side is widely opened. However, 2 aligned balloons cause a stent deformation to the elliptical, and malapposed strut was shown. So therefore, this kind of the X-shape long overlapping causes non-uniform dilation at the proximal side. So we definitely agree that the routine performance of the angio-guided kissing balloon inflation should not be performed, which is likely to result in more suboptimal result. However, as the jet struts in the side branch ostium rarely safe forever, so we should know what is the significant side branch. In the slide, a previous speaker had been demonstrated. This is a computer simulation of the fraction of myocardial mass in bifurcated vessel from the coronary CT angiography. In the side branch of the non-left main, occupied only 21% for the vessels with percent fraction of myocardial mass more than 10%. Most predictive factor is the side branch length, more than 73 millimeter for this significant territory. However, we should know the prominent evidence for the gelled strut has an adverse effect on the clinical outcome. This is a 9-month follow-up OCT study of the J-reverse trial, and thrombus attachment is more prominent in the non-final kissing balloon inflation group on the J-strut, 38% versus 0%. In the non-final kissing balloon inflation group. And this is an autopsy study of the left main stent thrombosis from the CV pass. Here you can see a side branch ostial J struts occupied 1/3 of the fatal left main stent thrombosis case. These are the representative case. So the J strut has a risk of the fatal left main stent thrombosis. And this is another follow-up OCT studies. They investigate the correlation between the LCS ostium area narrowing and the J strut number. This is a case of the left main crossover stenting without LCS ostial dilation, without the LCS ostial dilation. Here you can see there is a positive correlation between them. That means the more J struts promote more LCS ostial narrowing. It's like seaweed culture, such as Japanese nori. So recently, FFO guidance is optimal, has been proposed as an optimal sideburn treatment in the following story. Member system stenting, sideburns compromise, angiographically sideburns seem to be more than 75% stenosis. However, FFR indicates more than 0.80, sideburn treatment differed. However, this is the actual condition of the sideburns ostium. Shifted carina located here, and jazz threat remained here. Indeed, remained jazz side branch ostium area does not show the side branch ischemia. However, we know this condition is much better than that. Shifted carina corrected to the normal position, and jazz threat completely removed, and stenotic side branch was released. However, we should know how often we performed these kind of suboptimal side branch dilation. So can we optimize the side branch dilation under the imaging guidance? Yes, we can with 3D OCT. In the previous lecture, I talked about the effective link connection on remain jazz struts after Kissen-Barron inflation. In the connected carina type, even after distal wiring, of the link connection still remained as a side branch ostium. And compared to the link-free type and the distal wiring, link connecting type has more incomplete stent apposition. And we investigate the success rate of the optimal wiring. Angio guidance guide wiring success rate is only 66%. So we recommend the 3D OCT guided optimal wiring, which can promote the optimal side branch treatment, which may lead to the distortion of the bifurcation coronary flow. Currently, we change the side branch treatment according to the side branch Jacek strand configuration. In the previous report, we divided the link-free type and the link-connecting type. In addition to them, we set the new concept, no or less J-link type. When we encounter link-free type, 3D OCT guided optimal guide wiring strongly recommended for the optimal side branch dilation. However, when we encountered link connecting type, 3D OCT guidance does not always lead to the optimal result. So we recommend the more aggressive part, which may induce the extension of further cell into the side branch ostium, which is more appropriate for the guideway recrossing. When we think the side branch is small, we can leave it. And more aggressive part can change the link connecting type to the no or less J-link type because the J-link strut widen the space. So when we encounter no or less J-link type, we can leave it with confidence except for severe side branch compromise. And part is crucial for the optimal guide wire recrossing before Kissen-Barron inflation. Port balloon should be located with the distal carina at the distal marker at the carina, because distal cell it widens the space. It promotes optimal distal wiring and decreases the malapposition around the bifurcation. When the port balloon located more proximally in suboptimal type, only a proximal cell dilated like this, which promotes the proximal guide wiring and increase the malapposition. So 10 years ago, I proposed a minimum overlapping Kissen-Barron inflation combined with port, which can promote uniform dilation in the proximal side. Comparing to the conventional Kissen-Barron inflation, long overlapping type, here you can see no uniform dilation in the proximal side was observed. And in the computer simulation, we demonstrate this kind of elliptical stent deformation causes flow retardation in the over-dilated side. It may lead to the atherosclerosis or thrombosis in the future. My concept is clearly proved in the large-scale clinical study recently, Lane registry from Italy. 2,700 patients enrolled in the study. Short overlapping kissing balloon inflation indicated by red bar is effective to reduce the TLR irrespective of pod. There is no advantage in long overlapping kissing balloon inflation indicated by purple bar compared to the blue bar in the non-final kissing balloon inflation. And using the non-component balloon is effective to reduce the edge dissection due to overexpansion in the bench testing. And this efficacy is proved by a clinical study from France and Korea. And I recently proposed the usage of the short balloon for the side bench dilation. Compared to the long balloon, using the short balloon has an advantage to decrease the member stent deformation, which is likely to occur at the opposite side of the side bench, white arrow indicated here, due to the straightening of the balloon to the direction of the red arrow. And short balloon minimize the dissection at the lateral side of the side branch. So European Bifurcation Club recommends the following manner for the kissing balloon inflation in the provisional stenting, member stenting according to the distal member size and the part and the distal wiring and the minimum overlapping kissing balloon inflation like this and report. And the second part is the efficacy of the kissing balloon inflation on two stent. This is a movie, first movie of the vascular endoscopic observation after cross stenting in animal experiment 15 years ago. I presented this movie in the European Bifurcation Club. There is great impact on the European doctors because multiple layer overlapped stent attach the thrombus. So kissing balloon inflation is strongly recommended to reduce malapposition at the strut overlapping side. This is another case, left main 111 lesion. My colleague treated with lesion, the curate stenting and kissing balloon inflation. At that time, he didn't know the precise concept of the part, and he used a long balloon for the member dilation. This is the final angiogram. Here you can see cardinal deviation to the SX was found. Around 1 year later, he returned to the cath lab because of the recurrence of the angina. Here you can see severe stenosis in the L6 ostium. OCT shows the cardinal deviation to the L6 and intimal hyperplasia in the L6 ostium. So shifted to metallic carina causes the flow turbulence at the L6 ostium, which promotes a recent region. So kissing balloon inflation is recommended to correct the deviation of the metallic carina in the two stenting. And the stent expansion is also crucial for the two stenting technique. From the Asan left main registry, they propose this 5, 6, 7, 8 theory for reduce the TLR in the left main bifurcation two stenting. A similar analysis was performed in the EXA trial. Dr. Maihara found that Caucasian people required more stent expansion, 6 millimeters square for SX ostium, 7 for LED ostium, 10 for proximal left main. Refrain kissing balloon inflation is a powerful tool for stent expansion. And in the Lane registry, compared to the provisional stenting, two stenting cohort, final kissing balloon inflation has a significant advantage over the final kissing balloon inflation to reduce TVR or TLR. I'll return to the first question. What is the purpose of the kissing balloon inflation? We should know the efficacy of the kissing balloon inflation is limited in the following role I previously mentioned. Only effective role is prevention of carina shift and the optimal size side branch dilation. In the two stenting, the large expansion, the decrease in the stent malabsorption is effective. And we should know the complementary use of the following are necessary. First is a part. The second is the minimal balloon overlapping. And third is the side dilation with a short non-compressed balloon. And fourth, the optimal assessment of the guidoid crossing or side branch jailing strut by 3D OCT. Thank you for your attention.
Thank you very much, Dr. Murasato. Many questions from the audience already about kissing balloon inflation. One question that keeps coming up several times is that if we have not planned two-stent technique and the technique is just one stent, and if the side branch looks great after the implantation in the main branch stent, would you still do a kissing inflation?
Yes, if the side branch is a significant territory, we routinely perform the kissing balloon inflation or side branch dilation. So the removing the jazz strut is very important to research the flow circumstance in the bifurcation. Natural coronal flow is important. So jazz strut causes the flow retardation behind the strut. So we consider it is necessary to perform the kissing balloon inflation when the side branch has this great territory.
Well, certainly an issue of debate, right? Yeah.
Can I do a comment here?
Yes, please.
Yeah. Well, actually, what Murasato said now, I disagree completely. I mean, if you don't have any damage, any of flow on side branch, no ACG sign of any ischemia, no chest pain, and you see that there's no, I mean, it's perfect on angio. I think it is not needed. We don't have any support and scientific support for this. That means no studies showing that if you are going in this condition, going for kissing balloon inflation will improve your outcome. I think you might even have some damage also of the stent if you are trying to do kissing balloon and you do not have that much experience where to cross and how to cross. You can damage what was previously optimal. So I would avoid doing something in perfect angiographic result with no ischemia, with no chest pain, a TIMI3 flow inside branch.
However, we encountered the several cases without kissing balloon inflation, in the left main case, some cases demonstrate the centric region in the exit ostium, or the Dr. Belmani demonstrates that 1/3 of the left main fatal stent thrombosis cases occupies the jazz strut. So we worried about such kind of the jailing strut. So, and I also have a question for the panelists. When we did not the kissing balloon inflation, what is the optimal period for the DAPT in such case?
In my practice, it doesn't change. I mean, if I have good result, again, no damage, no compromise on side branch on angio, no ischemia and so on, I am not changing my diet prolongation. I mean, the same, and we do not have any sign of doing something wrong.
Anybody have any other opinions? Goran, Stankovic, and Niels want to say something?
Yes. So I think there's also a major discrepancy here between Japan and maybe almost the rest of the world, because you will routinely do intravascular imaging in your kissing cases. So in Europe and US, if you have a straight case and you want to open up the side branch ostium with kissing balloon inflation, if you have an otherwise optimal result, still few people will then use IVUS or OCT to evaluate the result. And then you have the risk because kissing balloon inflation is not a trivial task. It's error prone, so you can really do a good result bad if you don't control it. But in Japan, when you use imaging routinely, you can make sure you have an optimal result each time. So I think with the practice that we have now in almost everywhere else, if you have an otherwise optimal result in the side branch and you don't intend to use intravascular imaging, I think I will go with the angiographic optimal result and in those cases, so with the non-true bifurcation lesions.
I totally agree with according to our 3D OCT registry, angio-guided the guide recruitment success rate is 66%, and optimal side branch dilation may be less than 40% in the angio guidance. So if you perform the kissing balloon inflation under the angio guidance, I don't recommend the routine kissing balloon inflation.
But we are doing this in France.
Under the imaging guidance, the routine kissing balloon.
We are doing kissing without OCT in France. We like very much kissing since a long time. But we are following the rules that have been described by Yoshi. We define together the short balloon, the no overlap or reduced overlap. And we're doing this. We have, when I'm facing a big side branch, not all the side branches, someone is only for keep it open. But when I'm facing a big side branch, I do a kiss, always at the end.
Yeah, I would tend to agree. I mean, I think to say that, you know, we routinely don't do kissing in all provisional, it's not needed, is kind of one extreme. And I don't think any of us are saying that. And I just think, you know, to have a clear message for the younger physicians and fellows who are joining, I think you've seen that there is some variance in practice from, you know, Japan where it's routine to Europe where it's done when it's needed. So when there's either decreased flow or significant pinching of the side branch. And I think similar in the US. I think also for me personally, I have a lower threshold to perform kissing with provisional, like Yves says, when the side branch is very large or with left main. But once again, I mean, if you ask me, I show you the study that shows that, you know, a randomized study that shows routine kissing is better than not kissing? We don't have that data.
Absolutely.
Yeah, there are some data coming from actually combined registry of Dr. Colombo and Dr. Nakamura. And in that registry, in the left main, in provisional, there is no difference whether or not you perform kiss.
Yeah.
So crossover left main stenting with or without kissing provides similar clinical outcome. But as Yves said, since we are doing this for 30 years and with improved optimized technique, we still tend to do it more in the left main. And I have to accept that I'm more in European way, not to do it routinely outside of the left main.
Thank you very much, everybody. A great discussion. There's already been many questions from the audience about jailing wire in the side branch. And to address this very important topic, we have a very important person, Dr. Yves Louvard, who I mentioned his designation earlier, but he was the Lifetime Career Achievement Award winner for 2019. We actually have honor of having two of them here. Dr. Imad Sheiban is also one of the Lifetime Career Achievement Award winners of C3. So a great session. I will turn it over to Dr. Louvard now to talk about advantages and risk of jailing wire in the side branch.
Thank you, Raj, for this invitation. Of course, I regret not to be in Orlando, but I heard that it's not the good time to be in Orlando. So we have to deal with this problem this year, and we hope to see you in Orlando next year. The advantage and risk of jailing wire in the side branch. No conflict of interest. I just want to remember, it was cited several times in this session, that a bifurcation is a big tube and a small tube. This is a physiologic anatomy with the three diameters which are linked by the Murray's law and other formulas. It's very important to respect. So this is the reason that it was described already, why we use to put the crossover stent, the diameter of the main distal vessel. Of course, immediately after that, we have to do a pot for technical reason, or for opening the cell, favoring the crossing back to the side branch. If you use the main distal diameter, you have the risk first of oversizing the distal vessel with the dissection, and also the carena shift. And this is the carena shift by all OCT image by Patrick Sarois. And if you look at this shape of the side branch, you can understand why we see very tight lesion in the angiographic projection, while the surface of the side branch is not so small. So advantages of gel inside wire in the side branch is it changes the access angle to the side branch. It's a landmark in case of the side branch closure. And we can use with this gel wire some salvage techniques. And it was recommended also by Colombo when the side branch is not a branch that we think to put the stent in it, just to use the wire to keep it open. So modification of the access angle in the side branch. This is a case I did in this wonderful meeting in Belgrade. And you can see that there is a subocclusion of a diagonal, very tight lesion, with a difficult angle that we can see very well on the right here. So both branches were wired, and I did the crossover stenting. And after that, I used a technique that was described many times, but this is very basic technique for provisional stenting. You come back from with a properly shaped wire, you come back from the distal vessel, and you try doing that to enter the most distal cell. So we do that without OCT, Yoshi. After that, the patient was kissed with this result. And you may have judged that already now the angle is modified by the stenting, but it was also modified by the wire, and it helps you to make your wire exchange. And this is probably the first, not a publication, but presentation on this change of angles that we did in 2002 in TCT, showing that when the angle, the approach angle, the angle between the proximal main and the side branch is small, less than 120 degrees, then with the wire only, we can increase the angle by 33 degrees. So this is why we call this angle A for approach. It simplifies the approach of the side branch during wire exchange. Does the gel wire protect against side branch occlusion? This was discussed many times in the Bifurcation Club. We had a study in France showing that yes, having a wire in the side branch keeps the branch open. Just to remember, this slide just to remember, from Dr. Koo is to remember you what are the two components of side branch occlusion. The carena shift, which is related to the use of a too big stent diameter, and the plaque shift. And the carena shift is coming from distal, the carena, and the plaque shift is coming from proximal because there is no lesion on the carena, and the plaque is shifting from proximal. And to Dr. Koo say, in majority of cases, to occlude the side branch, we have the two phenomena. So is it a problem to have to occlude the side branch? Yes, of course, it depends on the size of the side branch. But this study coming from the registry in Korea shows that cardiac death or myocardial infarction occurs more frequently when we occlude the side branch. So this is not a benign event. These are some predictors found in COBIS-2. Of course, now we have many others. And the question in COBIS-2 in this trial was, is having a gel wire in the side branch protect against occlusion? You have gel wire in the side branch is the occlusion group in 66%, and in the non-occlusion group in 60%. So it's like the wire is inducing the occlusion. But if you look at, because you have an occlusion in the presence of a gel wire of 9%, and the absence of gel wire 7%. Of course, this is not different. But the most important is how the side branch is at the end of the procedure. The gel wire in the side branch is associated with recovery of occluded side branch. 74% versus 57%, and this is highly significant. So gelling a wire is a landmark, can be a landmark in case of side branch occlusion. So this is a case which have a tight lesion at the side branch. The angle is not so favorable, but you have to notice also there is a plaque on the side of the side branch, immediately proximal to the side branch is the main proximal vessel. So what is your opinion? Will occlude or not? I choose very quickly, I understood that I choose a too big stack. So here, I occluded the vessel. So what is your pronostic if you don't have a wire in this side branch? What is your pronostic for successful repenetration? For me, will be very low. So you can use also the gel wire for salvage techniques. Has been shown already, so I show it to you. This is using the gel wire to put a balloon to reopen a side branch which is occluded, mainly by Garena shift, but also some plaque shift. And you have to use a small balloon, that is was said, but I will add, you have to use a long balloon, because if you inflate a small balloon like this, then you try to pull back the balloon, then you will provoke a distortion of the proximal part of the stent. If you use a balloon long enough to cover the gel, the part when of the wire with the gel between the stent and the wall, it will be better. So this is the case I showed precedently. Of course, we have tried a lot of wires, even CTO wires, aggressive wires, and nothing was working. A double lumen catheter, nothing was working. So I used this wire in the side branch to push a 1.25 balloon in the side branch. You can see it was said already that I have a balloon in the main vessel. Immediately after opening, I observed this result. After that, we exchanged the wire from inside the stent to the diagonal. We did the kissing, and the result was really good. Don't show you. It was shown, this inverted crush technique was shown already by a previous speaker. What are the disadvantages of gelling wire inside? A disadvantage is the time that you take some time to put a wire in a side branch. And of course, the cost of an additional wire. But if you close the side branch, as it was shown in a previous case, don't you think that the time will be increased and the cost also will be increased? So we have several techniques has been shown. I showed this magnificent case of Dr. Murasato to put a wire in the side branch, even if it's very difficult. And this is a reverse wire technique. At that time was done without double lumen catheter, without micro catheter. Beautiful case. After that, he was able, of course, to treat the balloon, the side branch, stent the main vessel with a beautiful result. We can use a venture catheter, was shown, or other catheter shape, other catheters. And also another option which was not shown is rotablator assisted side branch wiring. The wiring was impossible. The case of my associate Thierry Lefebvre was impossible after that, even after a small pre-dilation, impossible. He did the rotablator. This was suggested the first time by another Japanese author, Dr. Saito. And he, after the rotablator, he did the balloon inflation. After that, he was able to introduce, using the inverted wire penetration, this wire in the circumference. What are the other, maybe more important inconvenience or problems with gelling a wire? Wire structural damage. Here, it will be, I'm speaking of the paper coming from the team of Manuel showing the structural damage to gel guide wire during the treatment of coronary bifurcation. Treatment with provisional strategy. It's a microscopic evaluation, and this is a very rare randomized trial with an endpoint which is microscopic. So this is a randomized trial, 150, 120 patients in a group with a polymer coated wire and a group with a non-polymer coated wire. I have to say that before this trial, and since a long time in the Bifurcation Club, we were saying that it's better not to use polymer coated. And it was mainly coming from our center because I remember I lost probably 2 or 3 polymer jacketed wire inside the site. But the result here showing some minor damage in polymer coated wire and major damage in non-polymer coated wire, as you can see here, or even worse, the core of the wire can be ruptured. But you can see that an additional advantage of the polymer wire is crossing more easily towards the side branch. I have to tell you, not only in CTO, that this polymer wire are also perforating more than a BMW. Just to come back a bit, lost this one. So it was microscopic damage was seen more frequently in non-polymer coated than polymer coated. But at the bottom of this slide, you can see that there is no real difference in follow-up events. Another problem was raised by Masoud Bissar in Bifurcation Club 2-3 years ago. Was a relationship between loss of pieces of polymer, probably not jacket, but only small pieces of polymer, and elevation of biomarkers, myocardial biomarkers. This has to be studied better. So a gel wire, especially in proximal lesion like left main, can create longitudinal compression. The so-called longitudinal distortion was described in a write by Anrati a few years ago. It shows that the stent is pushed in the right coronary artery here, distorting, and this is creating overlapping of struts that are seen like black dot like this that we can see here also. So the stent distortion can occur when you pull back too quickly a balloon, for example, in the left main. Your fellow is very anxious, deflate very quickly, pull it without deflation, and the guiding is engaging the left main. The guiding is on 2 wires, one is gel, one is not gel, so it's creating a lateral distortion, as you can see here. It can be also during the pullback of the gel wire, exactly the same problem. Is engaging, the guiding is engaging the left main and creating lateral distortion. And also in salvage technique can occur. And this has a clinical consequence.
If I may interrupt, I think that there is an issue with your slide advancement. Audience has been commenting that the slides are not moving forward.
Okay, but I'm very close to the end. I'm very sorry for that.
Sure, no problem.
A stent distortion in the left main, a longitudinal distortion in the left main. This is a sub-study of Excel with IVUS. So the distortion were detected, which is not generally the case. 6.5% of distortion were found in this group of nearly 500 patients. The MACE rate was significantly increased. There is a trend for an increase of the death rate. Left main related MI and left main ischemia driven TLR were increased a lot, and with significant, you can see. And here is the explanation that the guiding, when the guiding is pushing the strut, is pushing laterally the strut because there is a wire outside and wire inside. This is an example, was done by my fellow, I have to say, not by me, because I knew the problem before. And this is a long lesion from left main to LAD. This is positioning the stent from ostium that we were doing a lot, still doing majority of cases. The stent was deployed. This is before pot. And if you look very cautiously at the tip of the guiding, already you see that there is no stent at the ostium. We see that more better later. like this, for example, you see the guiding on the left, you see the stent, 5 millimeter distal. It was pushed by the guide. So in this case, you have to do the port, very important not to do an exchange of wire outside, outside the stent. After that, the wire are exchanged, a kiss was done. And of course, now you have to correct the non-stenting of the proximal left main with an additional stent. You can see here on the original stent, the black dot easily visible in stent enhancement with stent enhancement technique here. And this way we got a good result, but with an additional stent. So my conclusions are gel wire is safe, at least clinically safe. Today, I cannot say that it's better to take a non-polymeric stent wire, of course, but you have to take care also. The polymeric wire is crossing easier, but you have to take care. Remember that this is the provider of perforation. Less wire damage and quicker wiring with hydrophilic coated wires. Higher side branch patency rate at the end of the procedure if you put a gel wire, because of the landmark, because of salvage techniques. And gel wire is increasing the risk of stent distortion when you are dealing with proximal lesion like left main. But I have seen cases also with proximal LED. So it's very important to degel the wire immediately after the port. Thank you very much for your attention.
Thank you very much, Dr. Louvard. It was a great presentation. This reminds me to remind all the speakers that for compliance purposes in US, we require your slides as well as your speaker release forms. And if you can take a few minutes later today and send them to our administrator, that would be great. So lots of questions were answered about jailed wire in the side branch. Once I have Dr. Louvard's slides in the recording of this video, we will be able to provide the other slides that we were not able to see. Thank you very much. We'll now continue the program. Now it's a privilege to invite Dr. Manuel Pan, who is a consultant cardiologist and a professor of medicine at Reina Sofia Hospital in Cordoba, Spain. And it's an honor to have him here today. He is now going to talk about another very important subject. And there's already been lots and lots of questions about lesion preparation, when and how to pre-dilate the side branch. So that is exactly his talk today. And he will now talk about lesion preparation.
Thank you, Raj, for the kind invitation to this interesting meeting and my conflict of interest. The story of the side branch pre-dilation is an old topic in the Bifurcation Club. The topic has been discussed many times. Here you can see the first controversy in the second Bifurcation meeting in Rome in 2006 between Angela Hoye and Olivier Dan-Raymond. During this year, we continue discussing the pro and con of side branch pre-dilation and the possible potential advantage and disadvantage of the technique is summarized in this slide. Potential advantage are that pre-dilation could increase the vessel lumen and facilitate the rewiring of the side branch. Secondly, it could help maintain the side branch open with a good TIMI flow after main vessel stent implantation. And finally, it could be a definitive procedure on the side branch without post-dilation, without kissing, preserving the original geometry of the main vessel stent. Potential disadvantages are the occurrence of dissection of the side branch ostium that may hinder or prevent access to the side branch through the strut of the main vessel stent. And also the enlargement of the side branch lumen increase the likelihood of accessing the side branch through a proximal strut, not at the carina level, with the subsequent poor side branch scaffolding and potential increase in unnecessary side branch stenting. After the controversy in Rome, the second consensus appeared in neurointervention, and the consensus of the meeting was that side branch predilation was recommended if calcified lesion, if the patient presents calcified lesion of long lesion. One of the concern of the side branch predilation is the occurrence of the dissection at the level of the side branch. The question is, what type of vessel dissection produce side branch predilation? In our randomized study in 2014, we studied the type of dissection that occur after side branch predilation. As you can see in the slide, most of the type of dissection at the side branch after predilation were type A or B. We use an old classification of dissection after balloon dissection of coronary disease before the availability of the stent. At this time, this was an unuseful classification that then we forget. But for side branch predilation, I think it's useful, and the conclusion of the study is that most of the occurred dissection were mild, were no dangerous dissection that that allows for a rewiring of the side branch, as I will show you in the next slide. Another study, the COVID-2 registry, also demonstrate that side branch dissection, dangerous side branch dissection or severe side branch dissection, were low in both study groups, in group of patients with predilation or with no predilation. As a consequence of the type of the dissection, the side branch predilation, we think that does not hinder or prevent the access at the side branch. Here I can show you two studies. Our first study on the left that demonstrate that the time of rewiring was not significant between both techniques, but with a tendency to be shorter in the group of patients with side branch predilation. The number of used wire for side branch rewiring also was we need a less number of wire, with a significant difference between group in favor of the side branch predilation group. When we analyze the paper of Francesco Bursota, recently publicated in Journal of Invasive Cardiology, the predilation group also demonstrate similar advantage that that our previous study. The study of Francesco compare in non-randomized style patients treated with kissing predilation with patients without predilation. And as you can see in the slide, the side branch flow after main vessel stent implantation was higher in patients with predilation, with simultaneous predilation of the side branch and main vessel. The time, the need for additional wire was also lower in patients with side branch simultaneous predilation. Also, the failure of side branch rewiring was 0 in this group, as compared with 5% in patients without kissing predilation. regarding the TIMI flow after the pre-dilation, also also is better in the group of patients treated with pre-dilation. In our analysis, you can see that a significant difference in terms of TIMI3 was in favor of the group of patients treated with pre-dilation as compared with patients with no pre-dilation after main vessel stent implantation. When we analyze another paper, the COVID-2 registry, again, a similar result may be seen in the slide. Here you can see that the TIMI less than 3 was more infrequent in patients with non-predilation. And in the previous commented paper from Francesco, again the TIMI flow after main vessel stent implantation was better after the simultaneous dilation of main vessel and side branch. Another important question is if side branch predilation followed by the implantation of one stent across the bifurcation is a definitive procedure. You can see in the left in the table of our study that about 30% of the patients didn't require additional treatment of the side branch. So we avoid the sequence post-dilation or the kissing balloon inflation in this group of patients in about 30% of them, obtaining a good angiographic result without the formation of the stent, without kissing, without post-dilation, only with the implantation across the bifurcation and post. On the right, you can see an example of this situation. Is a lesion of a distal left main complex bifurcation lesion. The patient was pre-dilated toward the LAD and one stent was implanted from the left main to the circumflex. You can see the result. This is an excellent result on the side branch that does not require any additional intervention. So it's a super simple procedure without deformation, without need for crossing the strut of the stent and obtaining a good result. What about the follow-up of this patient treated with side branch predilation? Is side branch predilation prior to provisional stenting helpful or harmful? Some authors suggest that the predilation may increase the probability of MACE along the follow-up. This was a study from the COVID registry published in Revista Española of Cardiología simultaneously with our study. In this case, the authors suggest that predilation is associated with a higher probability of MACE during the follow-up. This is in contrast with our study, with our randomized study that was extended the follow-up up to 3 years. And as you can see, the probability of MACE was absolutely the same in both groups of patients. The same group that published the COVID registry in Revista Española of the Cardiología published 4 years later a second study in the COVID-2 registry in which the probability of MACE was the same in both groups. This discordance between the publication of the same group was explained by the use of a second generation drug-eluting stent in the last study and the type of selection of patient in terms of side branch size. Trying to answer the question of the title of the presentation, when use side branch predilation. Here you can see two examples of our randomized study in which the operator was unable to recross the side branch ostial severe stenosis after main vessel stent implantation. In the first example, the operator used low profile balloons and guideliner to increase the support, and despite of this maneuver, the operator failed to cross the side branch. And the second one is another complex bifurcation with an unfavorable angle with a severe stenosis at the ostial level. Again, you can see a severe percentage of stenosis at the level of the side of this diagonal after LAD stent implantation. The venture catheter was used to recross, but again, the balloon didn't cross. So probably this kind of lesion are candidate to have a side branch predilation in order to facilitate the side branch widening and the side branch passing the balloon. When? Another question of the title. The bifurcation consensus, the European Bifurcation Club consensus along these years and have maintained that predilation should be in long lesion and severe calcified lesion. In this slide, you can see the summary of the consensus of 2018 that say that predilation of the side branch is only recommended when access is difficult in case of severe diffuse and or calcified side branch lesion or compromised side branch flow after widening. In the last consensus that still is under review in euro intervention, the recommendation is still is a little bit more liberal a criteria of the operator and say that the side branch predilation is recommended when treating complex bifurcation with tight side branch ostial stenosis with tight side branch ostial stenosis. How is another important question of the procedure, and we can perform predilation in two ways, sequential or simultaneously. Sequential, if you decide to perform a sequential side branch predilation, we recommend that the main vessel to dilate first the main vessel lesion and then the side branch. If you decide another possibility is to dilate the side branch and then implant the main vessel stent. The size of the balloon, with this technique, you obtain a definitive procedure in about 30% of the patients, and you also can modify the technique and undersize the balloon in order to maintain the side branch open and produce at the same time less dissection. If you use a simultaneous side branch dilation, this is a technique that has been recently published by Francesco to maintain the bifurcation carina in its central location. That seems to be an important question before the implantation of the main vessel stent. This is a kissing, also you can call this technique as a pre-kissing before main vessel stent implantation, and the authors recommend the use of undersized balloon diameters in order to reduce the proximal dissection that could be an disadvantage of this technique. My conclusion, my personal conclusion, is that side branch predilation before main vessel stenting may facilitate the procedure. Improving the TIMI flow in this vessel after main vessel stenting does not penalize the rewiring of the side branch through the main vessel stent, despite the produced dissection. And in about 30% of the patients, pre-dilation plus main vessel stenting may be a definitive super simple procedure. Pre-dilation does not increase the rate of major follow-up and may be useful in complex bifurcation lesion with tight side branch osteal stenosis. Thank you for your attention.
Thank you very much, Manuel. That was a fantastic presentation, really well explained on pre-dilatation of the side branch. I'll open up for any comments from the panel members. Okay, so in the same thought of lesion preparation, we will now have another important topic by Dr. Azeem Latib, who is the Director of Structural Heart Interventions at Montefiore Medical Center in New York now, and also the most newest member of Scientific Advisory Board of C3 Congress. He will now talk about when and how to debulk a bifurcation lesion for lesion preparation.
Great, thank you, Raj. It's a real pleasure to be here with so many friends from C3 and EBC. It's getting quite late in the morning, and I thank all the participants for staying on so long. So I'm going to try and be brief and maybe just share with you a couple of cases. So why do we do lesion preparation? Well, very basically, because we do want to modify the plaque and we want to get a larger lumen. We know that lesion preparation facilitates procedural success, particularly when treating calcified or complex lesions. It allows delivery and full expansion of stents. Also, it modifies the plaques and changes lesion compliance. This hopefully minimizes vessel trauma, dissections, perforations, and allows us to have a larger MLD. So when do I debulk in bifurcations? Well, I keep it pretty simple. I debulk when there's true bifurcations and I see severe calcium in either or both branches. There's a lot of discussion of how you evaluate severe calcium. Of course, we can see it angiographically, and those are the easier ones, but more and more, I am using intracoronary imaging, particularly with more complex bifurcations, to try and evaluate the severity of the calcification. So the extent of the calcification, the thickness of the calcification, and the depth of the calcification will all impact how I use debulking. I also use it when I have incomplete balloon expansion, when I'm pre-dilating, and then in certain rare cases where I really cannot wire side branch, and I've tried everything else, lesion debulking, particularly with rotational atherectomy, can be useful. Certainly in my practice, I tend to use debulking more in left main than non-left main bifurcations, but it's really individualized to the anatomy and the type of bifurcation. So this is what the options are. And yeah, you know, we have many options. We have specialty balloons, we have laser, rotational, orbital atherectomy, and the newest kid in the block, shockwave. The one that I'm not going to be talking about, and I apologize to Yoshi, is directional atherectomy. It's also probably the device with the most clinical data available because the Japanese have really studied directional atherectomy extremely well in bifurcations. However, it's either not available or off-label in most of the rest of the world, and so I've elected not to talk about it. So let's maybe take you through two cases just to show you how I think about debulking. So here's the first case. This is a patient with a severe stenosis of the proximal LAD extending into the left main. And there's also this really, chunk of calcification here that you see, extremely calcific at the ostium of the left circumflex, which can be, very difficult to deal with. Of course, this is an inoperable patient that could not have bypass surgery. So here we started with the LAD. We rotablated with a 1.5 burr into the LAD, followed by aggressive pre-dilatation with non-compliant balloons. And that's just probably, you know, an important message to the fellows. The fact that you use one of these debulking devices like rotational atherectomy, orbital atherectomy, or even shockwave, as you'll see in the next case, doesn't mean that after you've used the device, you're now ready for stenting. You do have to follow the atherectomy device by the non-compliant balloons, really, one, to get good lumen expansion, two, to actually be sure that you've really impacted the calcium and debulked it. Because sometimes maybe the 1.5 burr is not enough and you need to use a larger burr. So here we then stented the proximal LAD with a long onyx stent that we were going to post-dilate larger, more proximally. And then we treated the ostium of the circumflex with an angiosculp. And despite you know, decent expansion with angiosculp of 312 at 28 atmospheres, so pretty high pressure, you see that there's still this sort of eccentric calcification. And I don't think you're ever really going to improve, or that we have a device that can really make that better. So we went on with our case. We now treated the left main. We decided to stent from the ostium of the left main to the LAD, overlapping with our previous stent. We used a 3.5 by 22 millimeter stent. We then recrossed to perform kissing inflation with, you know, and I think really important to be sure that when you do kissing inflation, that you really get full expansion of your balloons. And ideally, you know, you want to get a good result with full expansion. So here's the final result after doing kissing and a repot. I think a very good and acceptable result. We left the circumflex ostium alone. We really just did a provisional approach here. And probably I would, you know, in these cases, probably end the, you know, case with a drug-coated balloon if I had it on the circumflex ostium, if I was going to be provisional with so much disease there. So I'm going to take you to show you another case, a more recent case with maybe a different type of technology, just to show you two different technologies. And I think, you know, the more common technologies that I tend to use in my clinical practice. So here's a 77-year-old male, hypertensive, dyslipidemic, presents with an unstable angina, and has this really diffusely and severely calcified lesion in the circumflex, extending all the way to the ostium. I mean, a lesion that's really, I think, challenging to treat without, number one, debulking, and number two, without involving the left main ostium. And these very calcified ostial circumflex lesions are, to me, I think, one of the most challenging lesions we have still to treat, because we still have a very high incidence of restenosis in these types of lesions. You also see this diffuse and severely calcified lesion in the LAD. So really, you can see how you can see the artery when there's no dye. That's very apparent, the amount of calcium. So this is clearly the type of lesion, very complex, where I would want to do lesion debulking. Now, what technique could you use? I think the severity of calcium is to such an extent that you need something more than just a cutting balloon or a scoring balloon. So I guess one of the possibilities is to use atherectomy in this case. I'm a little bit, one of the issues with, I guess, atherectomy is, you know, this very angulated, very tight circumflex. If you're not experienced with atherectomy, you possibly could cause a big dissection, maybe even a perforation, if there's a lot of wire bias. So, you know, I think a lot of people are concerned about treating that kind of lesion with atherectomy. I would use rotational rather than orbital atherectomy if I were to do this with atherectomy. One of the limitations, though, with atherectomy is that, you know, you have to do one branch at a time. So you can't keep your wire in the other branch. So I think in contemporary interventional cardiology, this is the kind of case that I would try now with shockwave. So let me just show you some imaging. I think it's very important imaging in these kind of cases because they really do help dictate, you know, your strategy. And here you see really diffuse and severely calcified left circumflex. You know, you see really large areas of calcium in the circumflex and with large arcs of at least 180 degrees. It's not 360 degrees, but still quite extensive calcium. So we decided to use shockwave here. Remember the shockwave, you inflated it 4 atmospheres, you then deliver 10 impulses at a time of shockwave. After the 10 impulses, you then go to 8 atmospheres. and you can really give 80 impulses, so 8 sessions of 10 impulses per catheter, and then you have to change the catheter. So we started with a 2.5 millimeter balloon, and we did the first 4 treatments with shockwave intravascular lithotripsy in the proximal circumflex. We then went to the same balloon from the left main across into the circumflex. There are some concerns from people about using shockwave in the left main. You know, do you cause ischemia? Do patients, will patients tolerate it? Javier has actually got a paper that we all contributed to that's coming out in JACC Intervention, where we treated a whole lot of calcific left mains with shockwave with very good results. And interestingly, and I think not surprisingly to many of us, most patients actually tolerate it. You're not occluding the left main for a minute. You're occluding it for 10, 15 seconds, and most patients really are preconditioned and can tolerate that pretty well. If the patient can't, and you see their blood pressure dropping, you deflate the balloon, let them recover, and then reinflate and give you a shockwave. So it may just take you a little bit longer in the more unstable patient to deliver your enough shockwave impulses. So this is after the first shockwave. So I think, the proximal to mid-circumflex looks much better. The ostial circumflex, I think we'd all agree, still does not look very impressive. There's still a lot of, stenosis there, residual plaque. Could some of it be recoil? But we thought that really this needed to be treated again with a larger balloon. I think with shockwave, it is very important that you get to almost 1-to-1 with the shockwave balloon. So here we went with a 3.0 balloon. We gave 80 impulses, really treated that area extensively, then went with additional non-compliant balloons, 3.0 and then 3.5. And I think now you start seeing that we're getting a better, debulking and lesion preparation at the ostium of the circumflex. After that, we were fairly happy to start stenting. Our plan was to do systematic double stenting here, starting with the circumflex. So we put a 3.5 by 18 in the proximal circumflex, post-dilated with a 3.5 to 20 atmospheres, then a stent from left main to circumflex overlapping with the previous stent, also post-dilated, and then did a pot before then converting this to a culotte. This was the result after treating the proximal circumflex, certainly significantly better. And obviously, I'll show you the imaging at the end of the procedure. We then went on to treat the LAD. We also did shockwave and put 2 stents into the LAD. I'm not going to show you all the details for that, using a culotte technique to treat the left main bifurcation. So we had 2 stents, 3.5 and a 3.0 in the proximal to mid LAD. Here you see the post imaging was really very good expansion. In the segment that was treated with a 3.0 stent, we had an MSA of 5.39, acceptable considering how much calcium there is in this vessel. If you look at the circumflex, we had a small residual dissection distally, which we then treated with another stent. And here's the OCT. A is really the area I guess you're most interested in, which shows you this really severe ostial circumflex lesion. Remember how we really struggled to break the calcium there and debulk this lesion. And I really think, shockwave adds a new dimension to what we can do because 1, it's safety, and 2, it's efficacy. In this area, our MSA was distally in the most distal 2.5 stent where we had 4.26. But you can really see excellent stent expansion in the proximal area despite the extensive calcification. So just showing you again, this is what the LAD looked like before we treated with shockwave, and this is after a final stent implantation. This is the circumflex, remind you again what it looked like before, and then the final images after stent implantation. And here's the final angiography. Again, showing you excellent results. So I haven't shown you much data, but I thought it was more this time of the day and the long session would be more fun to look at a couple of cases and really share with you how I think of debulking and how I use debulking. And you'll see, and as you saw in all the cases I showed you, imaging really forms a very important part of my strategy for these very calcified bifurcations. I use the imaging to really try and determine my strategy, as in what device I'll use, as well as the size of my stents, and whether I'm going to do a provisional 2-stent strategy. And then I use it at the end to optimize the results as well. I'll stop there if there are any questions. Thank you for the opportunity.
Thank you, Azeem, for that wonderful presentation. We still have a solid attendance. We have crossed actually 1,000 today. We still have a lot of people listening, and it's a great honor and privilege to now invite our main leader of the bifurcation program for C3 and also the president of the EBC, Goran Stankovic. A lot of credit of this entire session goes to him. This is his hard work along with C3 advisory board to put together this program, and all of you to be with us today. He is a professor of medicine at University of Belgrade in Belgrade, Serbia, and one of the leading key opinion leaders in area of coronary bifurcation. So I've given him a tough job today. He's gonna talk about pitfalls, PAT, proximal strut recrossing into the side branch. Goran, it's all you. Goran, your mic is on mute. Goran, yeah, I can hear you now. Yeah.
Okay.
Yeah.
Okay. Raj, thank you very much for kind invitation to participate in this joint meeting with C3. And in the last 3 or 4 years, we really work every year more and more to join the forces and help education on both sides of the Atlantic. And thank you very much for kind words and support. As you said, you gave me a tough job, and it's again technical issue. And I don't have clinical data, unfortunately, to share, but I have some interesting concepts, and Dr. Murasato already presented some of the important aspects of recrossing into the side branch. And we all know from bench testing and from direct imaging from inside the bench that there are different cells which can be used for access into the side branch after main vessel stenting. And especially if we continue procedure with the kissing balloon inflation, this can create extremely high level of stent deformation inside the main vessel if we cross appropriate cell. And what bench testing also showed us is that we should try to do our best to cross the distal strut, because by crossing the distal strut, we have better scaffolding of the ostium of the side branch, and compared to proximal crossing, which really creates stent deformation inside the main vessel. To make sure that we define in different configurations optimal recrossing point, Dr. Onuma, the lead author of the joint consensus document of European Bifurcation and Japanese Bifurcation Club, he really, according to configuration, defined the optimal recrossing points in light blue. And what we can see here with direct visualization of the visible heart lab, we can see on the left side, we can see the ostium of the side branch, and we have wire, the upper one in the main vessel and the side branch wire crossing one of the multiple cells at the ostium of the side branch. What is important to understand is that if we try to visualize and to follow direction to go through the distal cell, then we clearly have in red very proximal and very distal cells, and those are definitely unfavorable for recrossing. We have intermediate cells in the central part in yellow, which are possible targets for recrossing. And what we see here, there are 2 cells which are distal ones and which are not link connecting. So as you may appreciate, we were able with direct visualization with angioscopy to cross in one of those 2 most favorable cells. And what is the consequence and why we are trying to go into the distal cell? Because if we are able to cross distally, aim to remove metal from the ostium of the side branch and partially scaffold also the ostium of the side branch can be achieved with balloon inflation towards the side branch as well as kissing balloon inflation. And you can see on the right hand side kissing balloon inflation with the lower balloon being in the side branch and the upper one inside the main vessel. And following balloon deflation, what you may appreciate now is that it's clear that distal position of the recross into the side branch really removed all the jailed metal from the ostium of the side branch. Carina is almost free of metal except for a very thin layer here, and you may see that some of the metal was projected into the ostium of the side branch, and therefore with one stent in the main vessel, we also partially scaffold the ostium of the side branch. And this is one of the secrets of the success of provisional, because with small amount of metal from the main vessel cell stent, we are able to scaffold also the ostium of the side branch. And what is the main problem with proximal recross in that case? As you can see here in these drawings, as well as in bench testing, yellow arrows point into the nova metallic neocarina. So if you cross proximally, when you inflate balloon, you actually push some of those struts into the main vessel stent, and you create artificially de novo metal neocarina. Also, those protruded and malapose struts result in lower strut coverage at the side branch ostium and more overhanging metal into the main branch after implantation of the stent. And you can see computational flow dynamic studies which clearly show stagnation with different aspects of the shear straight rate at the level of the metallic neocarina. In addition to having metallic neocarina, if we are not able to cross distally, if we cross proximally, then inflation of the balloon, as you may see, pushes some metal, creates this de novo neocarina, but then the next problem comes at the final proximal optimization technique. As you may see, by inflating balloon, at the end of the procedure, you actually push back this metallic neocarina into the ostium of the side branch, and now you actually increase the rate of the compromise and increase the amount of metal covering the ostium of the side branch. If you finish procedure with kissing, you may partially alleviate this problem. So by proximal crossing, you create metallic neocarina with final pot. If you do it in the proper site, in front of the carina, you actually push back metal into the ostium of carina, and you need to repeat another time kissing in order to push again metal from the ostium of the side branch, and then you have metallic neocarina at the end of the procedure. And this is a nice cartoon that was presented by Dr. Guan at TBC 2016. And since then, we are trying to understand the mechanisms of recrossing into the side branch and the reasons for not achieving optimal result, even if we go through the distal strut, at least angiographically guided. So we have a nice article of Dr. Okamura in Neurointervention 2014, and he used 3D OCT confirmation of the recrossing into the side branch, and he showed that link-free type of distal recrossing A was actually always resulting in better apposition, and the incidence of incomplete stent apposition was in free carina type at bifurcation segment predominantly. After final kissing balloon inflation significantly reduced compared to either proximal crossing or link connecting type. What is important is that after crossing through the proximal start and balloon inflation, even if we do kissing balloon inflation, this is one of the first publications, you may see residual metal at the level of carina protruding into the main vessel stent. And of course, a long-term outcome could be significantly impacted by persistent stent deformation inside of the lumen of the main vessel. In order to understand the potential consequences when we need to put the second stent, there were multiple published studies, and I selected one from Francesco Burzotta, Eurointervention 2013, in which he showed that with proximal crossing, we actually completely lack coverage with the metal of the ostium of the side branch. So if you want to put second stent into the side branch, you really need to pull back that stent long enough into the main vessel in order to cover this lateral roof aspect of the side branch, but as a consequence, you also have metallic neocarina created by the side branch stent. Contrary, if you cross distally, you are able to scaffold the ostium of the side branch, and then you can put your second stent in T or slightly protruding inside the main vessel stent. Another cartoon trying to clearly explain this one. So with proximal recrossing into the side branch, even with kissing balloon inflation, you actually have a minimal protrusion of the metal and minimal scaffolding of the ostium of the side branch. So if you look at the carina level, if you want to cover completely the lateral aspect which was not scaffolded, your stent needs to be pulled back inside the main vessel stent. If you go through the distal strut, balloon inflation will push the metal, scaffold the roof, scaffold the lateral wall of bifurcation, so your second stent will be in a T shape, not protruding inside of the main vessel. So after stenting with provisional, after performing proximal optimization, we open access towards the side branch, and then there are two possibilities. One, to achieve with the pullback maneuver distal recrossing, and with distal recrossing we have favorable deformation of the stent with protrusion of the metal into the ostium of the side branch. And second option is to cross proximally, but in this case, as you may see, even after kissing balloon inflation, we don't cover the ostium of the side branch. So if we want to make sure that the whole area of bifurcation, especially the roof of bifurcation here in the lateral wall, is covered, we need to create metallic neocarina, and we need to pull back stent inside the main vessel stent. So in case of distal strut, likelihood of not protruding and finalizing procedure with T-stent shape is much higher compared to proximal or central recrossing, in which case we have to do tap, and degree of protrusion of the stent inside the main vessel stent actually depends also on the angle. And this is confirmation again from the visible heart. So here you may see the metallic neocarina. You can see full coverage of the lateral wall and the ostium. And on the other side, you can see metallic neocarina, which permanently remains inside of the main vessel stent. We don't have clinical evidence, but as you have seen in some of the presentations, there is a higher thrombus occurrence rate on those jailing struts and metallic neocarina. And this can partially explain our goal to do our best in order to cross distally. And here you have provisional T in blue. You have a second stent with minimal or no protrusion into the side branch. This is the aspect with the fly-through micro CT. And in T shape compared to TAP, in TAP you have slight protrusion inside of the main vessel stent. And these are fly-through images of both configurations. And I'm showing this just to, again, potentiate the efforts to do proximal optimization, to open access into the side branch, and then to use pullback strategy in order to do our best to achieve the distal strut. If we can cross in the distal strut, in that case, we push the metal, we cover the ostium of the bifurcation, and we don't need to intentionally protrude inside and create this aspect of stent protruding with metal permanently jailed inside of the main vessel stent. But what are the limitations? As Dr. Murasato showed, if we look just on geography, and this is after left main stenting recross into the circ, it's very difficult according to angiography to say whether it's proximal. So a worse aspect of the proximal is actually also the most distal strat, which is link connected, or we cross through the distal strat. And then if we do imaging, if we do OCT, we actually see that pot was not properly done. So our wire towards the side branch actually went completely out of the main vessel stent. And if we go now here with the balloon towards the circumflex, we will actually create longitudinal deformation inside of the left main stent. We need to use three-dimensional OCT with potential to visualize the recrossing point, and this may provide important information on the stent link location. So here in yellow, we can actually see directly or with OCT favorable struts to recross, or in red, we see actually distal struts, link connecting struts, in which even if we achieve distal recross, we are not able to completely remove metal from the ostium of the side branch. And the optimum study recently tested the feasibility and efficacy of online 3D OFDI guided PCI in order to evaluate the amount of incomplete stent apposition at bifurcation area, and study concluded that 3D OFDI guidance was superior to angio guidance in acute incomplete strata position, actually creation of metal of the bifurcation segment. But what is also important, even with OCT guidance, at least in 50% of cases, multiple attempts were required in order to achieve adequate position and to gain recross into the side branch through the most distal strat. If we cross proximally, or if we cross like in this case, after kissing balloon inflation, there are still metallic jail struts in front of the ostium of the side branch, which could not be removed. Dr. Nagoshi, in Jacek cardiology interventions in 2016, proposed the procedure of balloon push in order to remove those jail struts in front of the side branch using 3D OCT guidance. So after stenting of the main vessel and pot, which was done more proximal, and this is one of the most common causes of proximal recross into the side branch, then when we have wire into the proximal cell, the most problematic are actually those de novo metal neocarina in front of the bifurcation. So what they proposed is to use a low profile small balloon, go into the cell and push with low pressure 4 to 6 atmospheres. At the time when you cross into the side branch, you inflate to nominal pressure, and by inflating at this stage to nominal pressure, you actually push and scaffold those metallic neocarina into carina area, and you remove the struts from the main vessel central segment. But you see that with balloon inflation, you create deformation in the opposite side compared to carina. So you have to finalize with kissing in order to correct stent deformation in the main vessel. So we actually, from the flow, remove the protruding part of the metallic neocarina, and this has to be done, confirmed, and done with 3D OCT guidance. So it's my pleasure to conclude that guide wire crossing through the distal cell provides better scaffolding of the origin of the side branch and also reduces the incidence of incomplete stent apposition. Properly performed proximal optimization is therefore the essential step and should be performed before side branch rewiring in order to facilitate distal strat access. recrossing the proximal cell may result in creating de novo metal carina, and if second stent is needed, it favors T and protrusion instead of provisional T in those occasions. We really should consider use of imaging to guide our procedures, and confirmation of the clinical benefit is unfortunately still unweighted. I would like to thank the team of the Visible Heart Lab who really provided us with all those nice direct imaging and direct visualization of stent vessel wall interaction, which really helped us better understand stent behavior and also helped us to develop some procedures which could be safe. As Dr. Louvard showed, saving the side branch was actually based, and we learn from Visible Heart Lab images. Thank you very much for your attention.
Thank you, Goran, for that wonderful presentation. Beautiful images by the Visible Heart Lab folks. Great work. As usual, we'll continue with the program as it is late. I do want to make an announcement that part 2 of the European Bifurcation Club meeting regarding left main bifurcation will be next Saturday at the same time. There's already over 300 participants registrants for that. We have a limited number of spots for you being in the chat room. So please register early. If you missed the registration in a normal link, then you should be able to see the program anyway on Facebook Live as well. And the program will be available on the interventionalacademy.com website after the meeting. So we'll now continue with our last presentation. It's my pleasure to now invite Dr. Niels Holm from Aarhus University in Denmark, a close friend and also scientific advisory board member of C3. He will now discuss pitfalls of the final part, lessons from the OCT analysis.
Thank you very much. And thank you for the kind invitation to be here, joining this exciting session. Final pot and pot in general has been mentioned over and over again. So I think some of these messages that we'll have now are repeat messages. I have cut away a few of the slides, running a bit over time here at the end of the day. But thank you very much also to the audience to join the session at this late hour. So we have we have two types of pot. We have the early pot and the final pot. So I think it's very important to distinguish between the two types of pot. So the early pot is definitely a mandatory step to expand the stent to fit the proximal main vessel, to facilitate side branch access, as we have seen just in the previous session, previous talk, very important, and to reduce the risk of accidental abluminal rewiring. The final pot is a step to correct ellipticity caused by kissing balloon inflation and correct potential malposition and under-expansion of the main vessel if it still remains at this time. So let's just have a look at the early pot because some of the aspects, technical aspects, are common for both the early and the final pot. So in provisional stenting, where you just bend it across the side branch and you're doing as the next step the first pot, it is important to ensure that when you plan the stent length that you have sufficient proximal length to accommodate your shortest balloon. You can see here the position here, just as Goran explained, that it's very important to have a position depending on the balloon type where you push open the side branch. It should not be too proximal, but it's very important that you push the stent very near the carina level so that you facilitate a distal rewiring. But it's also important that we do not dilate too much proximal because we can then inflict dissections outside the stented area. So make sure you have sufficient stent length proximal if in any way possible. And also, please note when you plan this that if you intend to do a final pot, you already know now that you will do that. you may need even 2-3 millimeters more. So when you do pot both early and final, it's important that you realize that if you have longer stented segments across several segments, for example, here with 2 bifurcations, well, then you are also in principle doing several pots. So when you have stented, for example, here, the LAD across both the diagonal and the circ, well, then this is considered pot segment for the diagonal, and this is the pot segment from the circ. Sometimes you see that people just use the same non-compliant balloons all the way up, but make sure that you accommodate and use the correct balloon according to the reference size. And this is both for the early pot and for the final pot. So how do you estimate the reference size? Well, as we have heard over and over again, intravascular imaging is the gold standard. You can use IVUS or OCT, both with pros and cons. But it's also advisable to have this chart. It's from a now quite old publication, but it's still very useful to have on the boom arm, where you have the relations between the daughter vessels, the distal main vessel and the side branch, and the proximal main vessel. That can be very helpful in assessing the reference sizes. So it's certainly also important to do early pot in 2-stent techniques. Here is an example with the culotte technique where early pot was not performed. So you end up rewiring on the outside when you want to rewire the LAD in this example here. So instead of being inside the stent, you're on the outside, and with the balloon dilatation, which is planned for opening the LAD ostium here, well, you actually accidentally crush the proximal part. And from there on, everything goes wrong, and you end up with a crushed segment here, and the patient is back in the lab with stent thrombosis after 13 months. You can see the compressed stent down here, simply just because the operator did not, the physician did not do an early pot. You know, with the culotte, there are 2 steps where you need to do early pot, and that's after each stent implantation. So another example of the culotte, here we have stent implanted from the diagonal branch into the proximal LAD, and we have now rewired the LAD for opening up the ostium to the mid-LAD here. So the early pot that was done here was done with a stent balloon. So it's a 3O stent that has been implanted, and then the physician retracted this balloon and then inflated with high pressure and used that as a pot here at this time. So this is the resulting OCT, just here proximal to the LAD. And as you can see, it's not completely opposed, and you can see also high risk of wiring on the outside of the stent. And you can imagine if you dilate next time here the balloon to open up to the LAD, well, there's a high risk of crossing this. It's actually quite sure you will end up crossing the stent accidentally. So for the culotte, it's important to have the 2 early pots, but it's certainly also for the DK crush, where you have the early cross. It's not exactly a early pot, but it's an early additional cross, because you can see if you use the balloon sized according to a distal main vessel, you can have kind of incomplete cross, again with risk of the rewiring through the true lumen of the stent instead across the side of the stent. So make sure you bring out the pot balloon very early, so you repeat the early the crush also with the pot balloon to again have a safe rewiring. So an early pot is definitely mandatory. Use 1-to-1 sized non-compliant balloon. Have a balloon position depending on the balloon type, so you make sure you open up the side branch ostium to facilitate the rewiring, and make sure that you do this pot after each stent implantation in culotte and also twice in DK crush. So the final pot, well, the final pot is a step that you typically add, of course, in 2-stent techniques, but in any case after kissing balloon inflation that causes the ellipticity of or the deformation and the oval shape of the proximal main vessel. There are some concerns about the final pot, as already have been shown. And today we have in the session Dr. Murasato, and he, at the same time as we started working with this, he published this case here, where after side branch opening, there was created a metallic carina, and then the final pot actually pushed to that metallic carina and bended it inwards into the main vessel, and he had to leave behind this problematic result here. So, how do we deal with this? Well, this is a case, a TAP case, where we also had some concerns about final pot. So we have actually finalized here the procedure, but only missed to do the final pot. So a stent is implanted in the diagonal branch. So first here in the LAD and then in the diagonal branch. And now we're doing an OCT pullback here. We are satisfied with the angiographic result, but we also see that maybe it's slightly underexpanded here in the proximal main vessel, so we certainly want to do the final pot. But an OCT pullback was performed from the diagonal branch and into the main vessel, and we can have a look at it here. If you follow up here on screen, you can already see now here we have a bifurcation area, and we get now to the side branch. Here's the side branch opening, and you can see we have a long protrusion of the stent, the side branch stent, into the main vessel. So should we now perform final pot? Well, I've indicated here with the markers where you actually have the proximal edge of the stent. From the side branch stent, it's here, and this is the proximal stent edge of the main vessel stent. So this is, could be say, okay, it's a mistake by the physician to implant the stent so proximal, but actually in reality, we are frequently cheated by the angiogram despite doing more than 2 projections to check the position. And it is a problem, for example, with a TAP technique that you can have a quite long metallic carina. So make sure that you do a good pre-pot, a good early pot to have the good expansion, because at this time here, it could be problematic. So this is from the main vessel. We can now see here the long metallic carina. And if we do now a final pot, we will certainly jail the side branch. So we can consider repeat kissing, maybe to have a more mid position or of the metallic carina, or we can convert it to an internal crush, rewire, and then do an additional final kissing balloon. In this case, the physician decided to leave this result, well, the patient has done fine without events, but it's certainly a matter of concern if you just do a final pot here and leave side branch jailed. We know that jailed side branch in 2 stent techniques is associated with increased mortality. So this is a bit difficult to investigate in clinical case, because if you do OCT before final pot and you know there's already a problem, then you certainly don't want to do final pot across the side branch takeoff, because you can really have problems of getting out of troubles after that. So in collaboration with John Ormiston, we did this bench test here where we inflated balloons across side branches where we have intentional created metallic carina by a proximal rewind. And as you can see here, we move, of course, the metallic carina towards the side branch, but we also have another effect. We actually reduce the area of the side branch ostium. And actually that was quite pronounced. So if we had a distal rewind, so a good rewind, well, then the reduction of final pot across, these are the red lines, was about 1/3 of the area. Whereas if we had a proximal rewind where we create a long metallic carina, we can see an almost 50% reduction in side branch ostial area by doing a final pot across with a balloon across the side branch takeoff. This was in comparison to if we did final pot with the balloon in a position proximal to the side branch takeoff. So we did not cross the side branch takeoff. So the conclusion from that bench study, which is quite elaborate and not show everything shown here, was that you need to stay clear of the side branch ostium, in particular if you have a metallic carina. a very busy slide here, but also showing in this publication where we saw the effects of proximal final pod versus final pod across the sideburns takeoff. It was quite evident that if you have distal rewiring and do the final pod proximal to the sideburns takeoff, then you get the absolute optimal results compared to all the other combinations. So just to echo the remarks by Stankovic, it's definitely beneficial to have distal rewiring on all the subsequent aspects, and in particular also if you want to do final pod. So we had quite a number of papers showing that when you perform the final pod, you should actually cross the sideburns takeoff with the balloon. And well, we are not so happy for that. And luckily, we have now the new EBC white paper, which is highly recommended, where the balloon is indicated with the final pod not to cross the sideburns takeoff. So in comparison here, the final pod is mandatory in repod. That's the pod side pod technique. And of course, if you still have under expansion at this late point in the procedure, you still use non-compliant balloons. Balloon position proximal to the sideburns ostium is highly recommended. And in provisional stenting, make sure you have distal rewiring to avoid the worst problems with final pod. And also know that two-stent techniques, in particular TAP, are prone to long metallic carina. So in summary, early pod is definitely mandatory. Use one-to-one sized balloons, preferably non-compliant balloons. Position the balloon to open the sideburns ostium. Make sure you do 2 early pods in culotte and the DK crush. IVUS/OCT may provide accurate reference sizes, and multiple pod inflations may be required to cover longer proximal main vessel segments. The final pod is mandatory in the pod side pod technique, but else, if you do it, balloon inflations should be done proximal to the sideburns takeoff, and intercoronary imaging is highly recommended. Thank you very much.
Thank you very much, Niels, for that outstanding presentation. Unbelievable session. There is a ton of questions. However, I don't think that we're way over time. So I won't be able to address some of these, but I'm going to answer some of these questions after the session for folks who have been asking questions online. And I will also answer some of the questions from the Facebook Live platform. But thanks all the faculty who's taken a very valuable time today to be here as a part of the EBC Part 1 session. I know it's in some of the areas like Japan, it's very, very late. Dr. Murasato was very kind enough to be with us, even though it's extremely late in Japan. So I want to close this session today. I want to make sure that I invite everyone for next Saturday for EBC C3 joint session on left main bifurcation. It's going to be as exciting as today with another set of fantastic talks and an outstanding faculty as it is today as well. So thanks all the faculty. Have a wonderful afternoon in Europe. Have a great evening and night in the rest of the world, as we have today attendees from 40 countries, and I thank all of the attendees to trust their spending their valuable time on the weekend for their education to rely on C3's online platform. With that, I'd like to conclude the session. Thanks again, everybody. Have a great rest of the day. Thank you, Goran. And thank you, Dr. Pan. Thanks to everybody.
Thank you. Bye-bye.
Thank you. Bye-bye to everybody.
Thank you, Imad.
Thank
you.